Hello and welcome to the Health and Government Operations Committee. The Vice Chair Pena Melnick, who normally chairs on Wednesdays, has a hearing in judiciary, so she will be out temporarily. When she returns, she will take my place. Just a note for the public, we do have members who are coming and going because they have committee hearings in other committees. We have 8 bills today and 46 witnesses. Just a reminder for our rules, the sponsor gets 5 minutes to introduce their bill, and then we will hear from up to 5 proponents with 2 minutes each, 5 favorable with amendment and 5 unfavorable if there are those folks signed up. The bill order for today is House Bill 786, House Bill 570, House Bill 668, House Bill 694, House Bill 715, House Bill 906, House Bill 746, and finally House Bill 1080. With that, I will call the first bill of the day, which is Delegate Bridges, Health Records and Reporting Overdoses, Limitations on Use in Criminal Investigation or Prosecution. Welcome, Delegate Bridges.
Thank you. I appreciate it. Thank you, Madam Chair, members of the Health and Government Operations Committee. Thank you for the opportunity. Thank you for the opportunity to bring this bill before your committee. House Bill 786 is actually an administration bill for the city of Baltimore. And Natasha Mayhew, the legislative director for the mayor's office, is also here to testify on this bill along with another member. The purpose of this bill is really to prohibit the use of patient information in the event of an overdose, so that individuals are more comfortably able to seek emergency medical services without fear of inviting criminal investigations or prosecutions. So in response to the prevalence and severity of drug overdoses, this original legislative law from 2018 actually required emergency medical personnel to report overdoses to an overdose mapping application. And while this application information could serve several purposes, leveraging this information for criminal investigations and prosecutions was prohibited. So the intent of confining the use of this information was to ensure that individuals would more reliably seek emergency medical care. However, the city's administration concluded that the patient information was also being separately stored in the individual's medical records. So as a result, enforcement officers were bypassing the mapping application and actually retrieving the patient information from medical records as an alternative. In this limited interpretation of the original bill, patient information was being used in ways that were meant to be prohibited. So what this bill does, and the amendment clarifies the intent of this original bill, patient information stored in the mapping application or medical records can't be utilized for purposes associated with criminal investigations. In effect, it emboldens the distinction between people seeking emergency medical assistance and those requiring more rigorous interventions with law enforcement. As a result, the amendment is needed within the bill to protect patients' information housed within both medical records and the mapping application. We also have a sponsor amendment which strikes law enforcement officers and substitutes from an overdose patient's medical record, which further clarifies that we're seeking to protect the individual's medical records only. The loophole that was created in 2018 actually waters down the protections of people who may call 911 or feel the need to give false information when they do so. Passing this bill will close that loophole to allow law enforcement to separately access patient information from medical records. In turn, the bill can help fulfill the goal of encouraging necessary, life-saving emergency medical care that can mitigate harm caused by overdoses. In conclusion, I hope that this committee and all the voting members will be willing to provide a favorable report for House Bill 786 and protecting patient information so individuals confronting overdoses can reliably seek emergency medical care without inviting criminal investigation or prosecution. And with that, I am more than happy to either try to take questions. I know Natasha Mayhew is probably the person that has more information than I do, but I can try to take questions, or if I could turn it over to the person that actually, the administration, to answer questions as well, I'm more than happy to do that.
Sure. So Delegate Bridges, you have 2 minutes left on your clock. I don't have Natasha Mayhew signed up. I do have Ann Seacott signed up. So why don't we hear from Ann Seacott? I don't think Natasha Mayhew's here, but I would imagine Ann Seacott can probably answer questions. So
Natasha is here.
Oh, she is. Was she expecting to orally testify with your extra 2 minutes? Let's hear from Natasha Mayhew then.
Great, thank you. Natasha May here on behalf of the Baltimore City Administration in support of House Bill 786. I do want to thank Delegate Bridges for introducing the bill on our behalf. As he noted, it does close a loophole. This bill clarifies the original intent of the 2018 law that required the emergency medical service providers, such as our municipal fire department medics, to report overdose information to the overdose mapping application. That bill prohibited the use of that information for criminal investigation or prosecution. So the intent was to ban the use of any medic-provided overdose information for those purposes. It was to serve as a privacy protection for overdose victims, to shield their medical records when they call 911 for an overdose. So the problem we were seeing is that some people viewed this ban as more limited, merely preventing criminal investigators from taking the information directly from the mapping applications while still allowing them to obtain the same information from the separately maintained medic-created medical records. This goes against the intent to help keep overdose victims alive by making sure they do not fear criminal investigations, and goes against the intent of dissuading, preventing them from seeking help. So by clarifying that criminal investigators may not obtain this information directly from their medical records held by the emergency service providers, this bill maintains that key distinction between seeking emergency assistance and investigating criminal behaviors. So as the sponsor noted, our amendment just further clarifies we are seeking to protect medical records. And as I mentioned, the investigators, this includes officers, attorneys, prosecutors, juries. So again, it closes a loophole under the original intent of the bill. And with that, we request a favorable report with the amendments on House Bill 786. Thank you so much.
Thank you very much. Let's hear next from Ann Seacott, and then we'll go to questions. Delegate Kaiser. Ann Seacott.
Thank you, Madam Chair, members of the committee. I'm Ann Seacott on behalf of the Maryland chapter of the National Council on Alcoholism and Drug Dependence. You also have written testimony from the Maryland DC Society of Addiction Medicine in strong support of the bill. I was before this committee in 2018 supporting the legislation that created this reporting mechanism. And the assurance that we got was literally in the bill that the data would not be used for criminal investigation. And that's what made us very comfortable with the idea that this data should be collected for surveillance purposes so that we could see where spikes in overdoses are taking place, so that we can try to help determine where naloxone should be distributed. So it seemed like a very good thing. To hear that a loophole is being exploited in order to allow for criminal investigation speaks to one of the problems we have in various sectors related to the unfortunate, very warranted mistrust that people using drugs have when it comes to law enforcement. We see this with our Good Samaritan law, where we see people being charged with crimes not specified in the law that people can't be charged with. It's why we have come before a different committee repeatedly asking for decriminalization of paraphernalia. So these are all ways, but what you have heard a lot of is about trying to reduce law enforcement presence in crisis response. It all fits a theme, and that's that if we want to truly save people's lives, we need to have a much more pure public health approach to the issues around opioid overdose. So with that, we ask with the amendments, the sponsors' amendments, support for the bill.
Thank you very much. Let's go to questions. First up is Delegate Kaiser.
Thank you, Madam Chair, and thank you, Delegate Bridges. My question might be off topic a little bit, but I was just wondering, did that old law or this current bill address, could this information still be public in some kind of way when there's custody agreements or something else? If one of the parents has had an overdose and was not supposed to be using anymore, is it allowable in those situations?
I would defer it to Ms. Mayhew.
I would have to look into that, and Anne might have a little bit more information on the specifics. This is a little outside of the scope of our specific bill, so I'm not familiar enough to know about the custody issues.
I'm not aware of what health records, health incidences that are recorded in people's health records impact custody decisions. So you know, and that's I think the point of the bill, and I think the point of the original law as well as this bill. This is about people's health records, and so any of the privacy protections that exist need to apply to all of it. And I just don't know what other examples there may be, but of health records impacting custody decisions.
Thanks.
Thank you. Delegate Johnson.
Thank you, Madam Chair, and whoever's best to answer. How are they gaining access to medical records? Did they get a warrant, or how exactly were they gaining access to medical records?
So as we understand, they'll, provide their services, and then they upload that information to the mapping database. And that database is used to see where there's spikes and overdoses, that sort of information. And the loophole was that they would then go, since the law says you're not supposed to pull it from there, they would approach the medics to get the information directly from the medic, the information the medics themselves keep on their responses. I can't answer for certainly if that's the warrants or other means, but that is at least what we have been seeing in terms of the loophole being exploited.
A follow-up, Madam Chair.
Sure. Yeah.
So the real problem is not them accessing the map, but going to the medics. Is that correct?
Yes, and that's what the amendment seeks to close the loophole by specifying it's the medical records. So whether you're getting it from the mapping database or directly from the medics, you can't use that information in the criminal prosecutions or investigations.
Okay, thank you. Thank you, Madam Chair.
Delegate Chisholm.
Thank you, Madam Chair. I just want to make sure I understand this. I understand wanting to mask the private, the personal information, but will the mapping still allow law enforcement to identify certain areas with spikes? Because obviously if fentanyl hits a certain community and they have a large amount of spike or a lot of overdoses, they can pinpoint that there's a bad drug or a potentially fatal drug. This will not inhibit them from doing that. Do I understand this correct?
That is correct. This just clarifies the intent of the original law. It still fully allows the mapping application to be used to pinpoint those spikes and overdoses.
Okay. Thank you. Thank you, Madam Chair.
Delegate Hill.
Thank you, Madam Chair, and thank you, Delegate Bridges. So whoever can answer this, I don't know who it would be. Has the state prosecutor or your Office of Law looked at why medics are releasing medical information at all? Medical information is privileged. That includes the name. Why are they releasing medical information to police without a warrant?
Yeah, and follow up to the previous question as to whether or not they're using warrants. That's not information I have on hand at the moment, but I'd be happy to reach out to our law department to get clarification on how exactly they're exploiting that loophole.
Well, my point, Madam Chair, if I may, I don't think there's a loophole here. I think, or my concern is that it's not that there's a loophole, is that someone is in violation of the law that existed prior to this bill and exists now, that you don't release medical records except under very specific circumstances. So this wall aside, there's an issue here about medical record release. Thank you.
Okay, I will remind the committee that we ask questions that are questions, and we try to keep our follow-ups limited to when we need a specific follow-up. But I think your point was an important one, Delegate Hill. I would just end it with, isn't that so? Delegate Krebs.
Thank you. And this is a statewide bill. And again, I'm trying to figure out exactly what the problem is, exactly as Delegate Hill was mentioning. It'd be nice to have some examples of exactly how you talked about going to the medic. But if you could provide some of those examples, and also law enforcement did not weigh in. Did you contact law enforcement? And it'd be nice to have them weigh in of why this happened, because this is statewide, and I do think there are some questions that need to be answered. I'd like to have law enforcement explain it. Have you been in contact with them?
Yes, I have been in contact with Andrea Mansfield, the lobbyist for the Chiefs and the Sheriff's Association. We did talk about that with them about the bill and with our amendment that clarifies the medical records. And the Chiefs and the Sheriff's Association have not taken a position on the bill, but we have been in very close communication with them. So they did not weigh in opposition or support. They decided not to take a position.
Okay, I'd like to follow up on that when we can. Thank you.
Thank you so much. That was the last question for this panel. We do have someone signed up favorable with amendments. That's Rajani Goodlavaletti. I hope I got your name right.
Hello, can you all hear me?
Your mic sounds a little fuzzy.
Okay, I'm going to try to be as close as I can if possible. Okay, thank you so much. Hi, I am Rajani Goodlavaletti. I am a Director of Mobilization with Baltimore Harm Reduction Coalition. And BHRC is an advocacy organization that mobilizes community members for the health, dignity, and safety of people targeted by the war on drugs and anti-sex worker policies. As a certified overdose response program, naloxone distributor, and syringe service program, we have provided essential healthcare services across the state for years. To supplement the life-saving services provided by us and dozens of harm reduction programs around the state, BHRC strongly supports HB 786 with sponsor amendments. HB 786 is an essential fix to existing law that shields victims of overdoses from having their private medical information shared in the course of a criminal investigation, which we have been discussing. What I want to really focus on is the community impact of this loophole that law enforcement have inappropriately created. Some law enforcement and prosecutors have interpreted current law so narrowly that they have created this loophole to disrespectfully access personal, private medical information. This loophole undermines the intent of the initial law, which was about public health. And it really perpetuates the culture of fear around reporting overdoses that already exists in communities across the state. We have heard from community members, naloxone trainees, syringe service programs, people over and over, they will not call 911 because they believe police will arrest, harass, or harm them. I would be remiss to add that I'm also a co-founder of the Bridges Coalition for Overdose Prevention Sites, which for 5 years, I and my co-organizers have urged this committee to publicly support. I'm currently right now in East Harlem, New York, speaking to you from the nation's first overdose prevention site, and it is a beautiful space. Right now, there are NYPD officers visiting this site, creating partnerships with this space. I really urge this committee to consider what we can be beyond having to figure out these technical loophole situations and really try to save lives from this overdose crisis. Thank you so much.
Thank you very much. Do we have questions for this witness? I do not see any hands up. Just giving one more second. It looks like we're good. Thank you so much for your testimony. That does conclude the hearing on House Bill 786. Next piece of legislation we have to hear is House Bill 570, which is Delegate Stein, pesticides, mosquito control products, and PFAS chemicals. Delegate Stein, welcome to HGO.
Thank you, Madam Chair and committee members. As you noted, this bill deals with PFAS in mosquito sprays. The committee is already familiar with PFAS concerns from the hearing on HB 275, the George Walker Taylor Act. Now, mosquito sprays are used by the Department of Agriculture in 2,100 communities each year. They're also used by private companies around homes, schools, and businesses. So this bill would ensure that when mosquito control products are used, they do not contain PFAS. The bill requires that manufacturers test for PFAS contamination prior to the sales and use of mosquito sprays allowing only PFAS-free products to be used. Now, the bill was prompted in part by findings by the Massachusetts Department of Environmental Protection. That agency detected PFAS chemicals in a number of mosquito control pesticides used in their state, including 2 products listed in MDA's program and a third that's similar to one used by MDA. PFAS was not a listed ingredient in these products, yet multiple PFAS chemicals were detected at concerning levels. For the 5 most contaminated mosquito products, the containers used are suspected as the source of PFAS in 2. As to the other 3 products, the source is not known, but the Massachusetts agency noted that it may be attributable to inert ingredients added to the pesticide by the manufacturer. 2 of these sprays, Vectobac and Maverick Perimeter, are currently listed on MDA's mosquito control program website as options. The first of these, Vectobac, contained almost 5,700 parts per trillion of PFAS, and Maverick contained almost 17,000 parts per trillion, a very high level of concern. So Maverick, given its, the second of these products, given its high level of PFAS, is a clear example of a pesticide that should be replaced with a PFAS-free product to protect public health and the environment. You will hear next from experts on why we need to turn off the tap on PFAS mosquito control products. We still will have numerous mosquito pesticides in the MDA toolbox. We should just not be spraying Marylanders inadvertently with PFAS, and it should be the manufacturers that test for safety. We're fortunate to have Dr. Birnbaum, the former director of the National Institute of Environmental Health Sciences, here today. She has decades of expertise on both PFAS and pesticides. And Madam Chair, I'd like to cede the remainder of my time to Dr. Birnbaum.
Excellent. Thank you so much. Dr. Birnbaum, you will have your 2 minutes as well as Delegate Stein's extra 2 minutes and 20 seconds or so. Dr. Birnbaum.
Thank you very much. I want to very briefly remind you of what the problems with PFAS are. This is a huge group of chemicals. Many are present as polymers, but in their life cycle, from their production through their use and then the end of their life, they can release the monomers of great concern. We have them because they provide stain resistance, water repellency. They're used in a lot of electronic equipment, but it's important to realize these never occur naturally. They are forever chemicals. They are all extremely persistent in the environment. They all move through the environment, and many of them are very persistent in us. They are used in more than 200 different use categories, and we are exposed to them from their presence in drinking water, from their presence in consumer products, and their presence in food as well. We also expose our infants because they are transferred from the mother to the infant in breast milk. These compounds have a plethora of adverse health effects. Nearly every organ system can be impacted, both during development and in the adult. There are many of these effects have been seen in multiple animal species, including humans, effects of cancer, effects on the immune system, effects on development, reproduction, effects on the liver, effects in the kidney, effects on our endocrine systems as well. We began studying these compounds prior to 2000s, but when 3M announced that they were present in the general population, the amount of research dramatically has increased over those past 20-some years. I think it's very important to realize that 3M, while they no longer, and the other manufacturers no longer make the intentionally added ones, such as PFOA and PFOS, the alternatives, when they have been tested, and very few, I would say, have been tested, they basically do the same things as the ones that are no longer being made. So we have over 12,000 chemicals in this class, and it's going to be essential that we take a class approach. There's no way that we can ever test 12,000 chemicals. We've used a class approach historically to things like PCBs, dioxins, PAHs, and it's certainly possible that we can use them for this class of compounds as well. Now, you may hear that PFAS aren't in pesticides, but that just is not true. Scientists have found have found them because sometimes they are intentionally added for their solubilizing properties. Sometimes they unintentionally appear because of the plastic containers in which they're stored, and that from the PFAS in the plastic can migrate into the pesticides. Important to remember that many pesticides are endocrine disrupting chemicals, as are PFAS. And many studies have shown that these kinds of endocrine disruptors act additively. You can get something from nothing. I think it's important to realize that that there are ways to test for these 12,000 chemicals. We only can test for about 60 specifically at this point in time, but Graham Peasley and others have shown that you can measure the total organic fluorine. If you have no total organic fluorine, you have no PFAS. If you have some total organic fluorine, you can then try to figure out by very sophisticated analytical chemistry what's there. EPA has promised to start regulating these compounds. It's been over 22 years that they've been working on 2 of them. Those will be released regulations on them in water by the fall of 2023. We can't wait for EPA to act. The states are moving ahead right now for both regulations in various products and in drinking water. Thank you.
Thank you very much, Dr. Birnbaum. Let's hear next from Eric Galley.
Sorry about that.
No problem.
My name is Eric Galley, and I'm here today on behalf of the Smart on Pesticides Coalition. I had other remarks prepared for you today, but then the fiscal note came out, and I really feel a need to address the fiscal note. If I can call your attention to the note, it says that MDA is asking for $2 million in the first year, almost all of it to expand their lab, equip the lab, and staff it with chemists. Future years budget the new chemists and the staff. The thing is, there's nothing in this bill that requires or even implies that MDA do any testing on anything. The meat of the bill is on page 2, starting on line 17. This language simply requires distributors to send MDA an affidavit that they have tested the product and have found that it doesn't contain PFAS. They also certify that the product was not stored in containers that contain PFAS. If the committee, in its wisdom, decides that it's not crystal clear that MDA doesn't have to test pesticides, we would be very happy to support an amendment that says nothing in the subtitle requires the department to test pesticides for PFAS. So I think with that, we're pretty much zeroing out the fiscal note. If the department needs a new clerk to handle the paperwork, we would be happy to endorse that. So in the past year or two, 2 state agencies, 2 advocacy groups, and the EPA have found PFAS in some of the pesticides those states allow for mosquito control. And one of those states, as you've heard, is Maryland. I sent out an email a few days ago with articles from the Baltimore Sun and the Bay Journal. I highly recommend them. They're a great overview of this whole situation. These products are sprayed throughout 2,100 communities around the state. You have written testimony from Dr. Kyla Bennett that talks about the history of PFAS being found in pesticides. So my point is, with all of this evidence in front of us, why wouldn't we want to take the very simple precaution of making sure these pesticides are tested for PFAS before they are sprayed in our communities, cities, and towns? And with that, I urge a favorable report. Thank you very much.
Thank you. Next up is Anna Rule.
Thank you. Thank you very much. Good afternoon. My name is Anna Rule. I'm assistant professor at the Johns Hopkins Bloomberg School of Public Health in the Department of Environmental Health and Engineering, and I support HB 570. As an exposure scientist focused on public environmental health research, I am concerned that PFAS has been found by EPA accredited lab in Permanon 3030, a pesticide widely used by the MDA for mosquito control. And as was mentioned previously, 2 other pesticides also listed in MDA's program were also found to contain concerning PFAS levels when tested by the Massachusetts Department of Environmental Protection. While additional samples provided by the MDA and Bayer were found to be PFAS-free in a later test, this only highlights what anyone in a lab can tell you, such as myself, that there is inherent variability in the samples and in every test method. This is why several samples of pesticides should be tested regularly prior to the registration for use in the state, to rule out potential contamination before reaching the environment. Testing samples of each pesticide at least annually is the right public health course of action. We know historically PFAS have been found in pesticides, and Dr. Bennett's testimony underscores this. You also have testimony from Dr. Grandjean of Harvard School of Public Health. His research found that PFAS diminishes the effectiveness of vaccines, elevates PFAS levels, and are associated with COVID-19 susceptibility, and also with more severe cases of COVID-19. I am very concerned that to date, there is no systematic testing of PFAS on mosquito control products, especially as Dr. Birnbaum mentioned, we know that both cause similar long-term health effects that have additive effects, especially in vulnerable populations like children and pregnant women. Thank you for a favorable vote on this bill.
Thank you very much. Next, we have Mike Ikniowski. Is Mike here?
Yeah,
there you
right
are.
here.
Excellent. Welcome.
I'm Dr. Michael Ikniowski, representing the Maryland chapter of the American Academy of Pediatrics, and I'm speaking today on behalf of Maryland's pediatricians and the many children in their care. PFAS are extremely stable substances that don't readily break down in the environment. Many are poorly excreted by the human body, with half-lives for some measured in years to decades. With this environmental and circulatory persistence, the potential for lifetime exposure and accumulation of PFAS in children is substantial. Children and fetuses are uniquely susceptible to the effects of toxic chemicals, a vulnerability that contradicts the misconception that the dose determines the toxicity of a particular substance. PFAS can cross the placenta and enter the fetal circulation, and exposures occurring when the brain and other organs are forming can have lasting impacts on an unborn child. PFAS increase the risk of preeclampsia in pregnant women and of low birth weight and decreased length and head circumference in newborns. Infants and young children also have greater exposures to toxic substances in their environment. They breathe more rapidly, they eat and drink larger amounts relative to their size than do adults, and their frequent hand-to-mouth behaviors increase inadvertent non-food ingestion, such as outdoor soil or contaminated house dust. Increased PFAS exposure has been found to reduce the response to many vaccines, to increase the risk of infections in children, to increase the risk and severity of COVID infections, and to increase the risk of congenital and acquired thyroid disease. Children should be protected from the harmful effects of these chemicals by reducing unnecessary exposures to them. The Environmental Protection Agency has yet to take action to assure that the mosquito sprays to be used this summer are free from PFAS contamination. In the absence of such action by the EPA, Maryland will need to confirm that these products are PFAS-free to protect its citizens, including children, from PFAS-related health risks. Because HB 570 would be expected to reduce children's exposures to PFAS, Maryland AAP requests a favorable report. Thank you.
Thank you, Doctor. Let's hear next from Doug Myers.
Good afternoon, members of the committee. My name is Doug Myers. I'm the Maryland Senior Scientist at Chesapeake Bay Foundation. We support HB 570, which limits the use and distribution of pesticides used to control mosquitoes. They're certified to have less than 100 parts per trillion. That of the PFAS, and this is an important part of the bill. I'm going to reference some findings from Dr. Vicki Blazer from USGS, who you have some written testimony from. In the PFAS compounds sampled in smallmouth bass blood plasma in 4 locations in the Chesapeake Bay, the study was finding concentrations in the fish of nanograms per milliliter, which is actually parts per billion, way more concentrated than the 100 parts per trillion threshold that this bill would address. Some of the concerns that Dr. Blazer's raising is lymphocyte functions in the fish, which produce antibodies, much like what you heard on the human health effects, are negatively impacted by PFAS exposure, and especially the ability for those chemicals to transfer up the food chain to humans that eat them. We do see that in most cases, fish tissues are bioconcentrating any of those kinds of chemicals to higher levels. And we are very concerned about the consumption of those fish from humans, especially in underserved communities that need to fish in a subsistence fashion. Alternative mosquito control pesticides are available that do not include PFAS. And I think it is often missed in a lot of the pesticide reviews because it's not considered the active ingredient, but it could be one of the inert ingredients. Some PFAS chemicals serve as the surfactant that makes the pesticide stick to whatever surface it's sprayed on. So for those reasons, CBF urges a favorable report on HB 570. Thank you for your time.
Thank you so much. We'll go to questions from the committee. Delegate Belcastro.
Thank you so much, Chair Kelly. And my questions for the bill sponsor, Delegate Stein. Delegate Stein, I'm trying to better understand the opposition to this bill. We're very familiar with PFAS here in this committee. And so my question is, one, are alternatives that are PFAS free widely available? And if that's the case, why is there opposition from the industry on this?
Thank you, Delegate. I will take a stab at answering that, but then would defer to any of my witnesses for further discussion.
Can I stop you right now, Delegate Stein? So we have a committee rule in HGO that we have one question, one answer. So if you have an expert, let's defer it to them if you think they're going to give the best answer.
Okay. I will defer to Mr. Galley.
I apologize for the fact that I did not hear the question.
Delegate Belcastro, would you please repeat your question?
Yeah, I'm trying to better understand the opposition to products that use PFAS in it. So my question is, one, are there products that are PFAS free, widely available in terms of pesticides? And in your opinion, if that's the case, in your opinion, why is there so much opposition to a bill like this?
Well, my understanding is that there were pesticides that were tested in these two cases that did turn out to be PFAS free. So right there, we have, there is a couple of commonly used products that have already been tested. But the whole point is, if we test these products, we can see who's in and who's out. We believe there are products that don't use it, and they will pass the test and we'll all be fine. But we do know that there's already been a couple that have passed that test.
Thank you. Delegate Rosenberg.
Thank you, Madam Chair. I have a question for Dr. Birnbaum. Why should we consider this bill when federal agency, the EPA, is working on it and will be possibly announcing its plan even this month?
The only thing that thank you for the question. The only thing that the federal government is specifically working on right now is the drinking water standards for PFOA and PFOS. The PFAS, which are present or have been shown to be present in certain pesticides, are neither PFOA or PFOS. Hope that answers the question.
Chairman Pendergrass.
Thank you, Madam Chairman. I'm sitting here looking at the $2 million fiscal note, and I heard somebody talk about something that would improve that to be something that we could manage. This is a bill that is very appealing, and I'm not sure why it would cost $2 million to implement, but I'm going to ask you if you could answer how we could change that, or if you will, before the subcommittee works on this bill, if you would see if you can come up with some amendments that would get rid of that.
Yes, Madam Chair, we believe that the fiscal note already is crazy, because the fiscal note anticipates MDA doing testing. But I would say that the bill does not require or imply that MDA should do any testing. This is simply about receiving affidavits and considering it when they're certifying. But if the bill is unclear, we would definitely support legislation that says nothing in this bill should imply that MDA should be doing any testing of anything. We think the fiscal note should be zero. And if they need one clerk to handle the paperwork that's going to come in, we're fine with that. But the fiscal note assumes that MDA will be doing testing. It talks about increasing their lab. It talks about hiring chemists. None of this is necessary for the scope of this bill.
Thank you. Delegate Hill.
Thank you, Mr. Galley. Are there reports or certifications, documents that manufacturers are now required, so that this wouldn't be a big deal to just give another one? And the same question with respect to this bill asks not only if it contains PFAS, but if it is in a container that ever contained PFAS. And that seems like asking for that kind of certification would be a lot. Can you help me understand if they normally give certifications and if that would be more excessive?
I'm going to defer to one of our experts, one of our scientists.
I think I can take part of that. What we know is that when pesticides are in the plastic containers, that's because a process has been used where the plastic is basically treated with straight fluorine. And as a result, PFAS are unintentionally made and present in the plastic. I think there are ways to know whether your plastic has that kind of problem. It's not all plastics, so I think there's a way to do that.
All right, thank you.
Delegate Riley.
Thank you, Madam Chair. Yeah, it looks like, one of the oppositions, to this is basically because we use this current pesticide mainly to, kill off mosquitoes. And we do know that mosquitoes do carry disease. So that's a health issue if we cannot control the mosquito, control them. So I heard you said that, there were some products out there that you're aware of. I think you said 2. So you're saying that we can move to that and get away from the PFAS, but are they tested, tried and true to know that they kill off the population for the most part of the mosquitoes? So that's the main thing.
I know that they were very common, they're commonly used ones, but we can get you full information on the ones that were tested and failed and the ones that were tested and passed. We can get you that information. But yes,
Okay.
There were commonly used pesticides that passed the test.
Okay, because it seems odd that, we would have such opposition on that if there was another product out there that was good. I mean, is it more expensive, or do you know any other issues about the product that you're talking about? Maybe if you could give that to us, it'd be great.
Well, listen, there is an opposition that never ever wants certain folks talking about pesticides in the Maryland General Assembly. They oppose us butting in on what they consider to be their thing.
Okay, all right. But like sorry, Madam Chair, like a follow-up, if you can get that to us, it'd be great to show us, the cost, difference and the factor of that it is, tested, tried and true, that it does kill off the mosquito population, and so on. So thank you very much. I appreciate it. Thank you, Madam Chair.
Thank you. Let's move on to the unfavorable witness, who is Megan Provost.
Thank you for the opportunity to provide testimony on HB 570. My name is Megan Provost, and I am president of RISE, Responsible Industry for a Sound Environment, the national trade association representing manufacturers, formulators, and distributors of specialty pesticides and fertilizers used by professionals and consumers. We respectfully oppose this legislation and request an unfavorable vote. Today, I would like to point the committee to 2 key reasons we oppose this bill. First, PFAS are not all the same, and it is not appropriate to group them together. PFAS are actually a diverse universe of chemistries that enable a huge range of products and sectors. However, all PFAS are not the same. It is not scientifically accurate nor appropriate to group all of these chemistries together. This is increasingly recognized by various government authorities and policy organizations, including the United States Environmental Protection Agency. Secondly, pesticides are already regulated and do not need to be separately or additionally regulated based on their ingredients. The Federal Insecticide, Fungicide, and Rodenticide Act and the Maryland Department of Agriculture's Pesticide Regulation Section already provide for the federal and state regulation of pesticide distribution, sale, and use, as well as stringent safety standards and oversight. These statutes already take into account human health, environmental, and economic impacts of pesticides, and are designed to evolve as science advances. Our industry takes great pride in its role protecting public health and our environment. Mosquito control professionals in Maryland rely on several methods to prevent the spread of mosquitoes, including both natural and chemical methods. However, it would be impossible to effectively prevent the spread of disease brought on by mosquitoes without the use of mosquito control pesticides. At this time, HB 570 will not serve to improve public health in Maryland, and we ask that the committee vote no on this legislation. Thank you for your time.
Thank you. Do we have questions from the committee? I do see a question from Delegate Johnson.
Thank you, Madam Speaker, or Madam Chair. For the Megan that just spoke, do you know of other pesticides that do not use PFAS?
The issue of concern here is the definition of PFAS and how it's defined in the bill. EPA has only released a working definition. In fact, in its PFAS roadmap that some of the other witnesses have referenced, EPA stated that they need to break the large, diverse class of PFAS into smaller categories based on similarities across defined parameters. The definition in this bill is very broad and would pull in potentially active and inert ingredients in some pesticide products that applicators in Maryland use to control mosquitoes.
So my question again is, are you aware of any other mosquito control pesticides that do not use PFAS?
So there are some that would, based on the current definition in the bill, that would not be pulled in. The challenge that we have there is our industry supports what we call an integrated pest management system. Applicators need numerous tools in the toolbox to control mosquitoes. If you limit those options, you can develop mosquito resistance. And applicators would have issues controlling mosquitoes just using, for example, one or two products over and over and over again. They need to be able to rotate methods.
Thank you, Madam Chair. Thank you.
Thank you. And I see no further questions from the committee. So that concludes the hearing on House Bill 570. Thank you to everyone for your participation. We'll move on to House Bill 668, which is Delegate Lasanti, Public Health, Removal of Health Officer. Delegate Lasanti.
Thank you, Madam Chair and honorable members of the committee. Mary Ann Lasanti for the record. It is my pleasure to bring to you House Bill 668 concerning notice to the state delegation of a removal of a health officer. Most Marylanders agree that public health should not be a political issue. Sadly, uncertainty, fear, and conflicting information wrongfully but understandably have injected political theater into policymaking. I know that this committee is working diligently to find a path forward. House Bill 668 adds an important element to the discussion, notification of the state delegation. This bill simply requires that the state delegation be notified of a request to terminate the employment of a county health officer prior to their removal. It recognizes the shared responsibility of public health between state and local governments. It also underscores the fact that each health officer is a state employee. I know that you've heard directly from the former Harford County health officer about the nature of his termination. In that case, and others statewide, there was no opportunity for state elected leaders to be briefed on circumstances prior to removal. Keeping elected officials, state elected officials, representatives, in the dark is simply wrong. Adding us to the process shall not be construed to impact the outcome. This bill does not seek to undo or pass judgment on terminations. The main purpose is to provide transparency and renewed trust in objective decision-making. The bill is simple to implement. It is meant to enhance public trust. The fiscal note indicates that the bill's requirement can be handled within existing budget resources and makes no material effect on government operations or finances, but it is impactful to the public. For these reasons, I ask a favorable report on House Bill 668. Thank you, Madam Chair.
Thank you so much. Do we have questions from the committee for the sponsor of the bill? She's also the only panelist signed up. So if you have questions, now's the time.
No. Not many activists for a policy bill. I got it.
Excellent. Well, thank you so much. With that, this concludes the hearing on House Bill 668. Thank you so much, Delegate Lasanti.
Thank you, ladies and gentlemen. Appreciate it.
Next up, we have Delegate Charkoudian, House Bill 694, Hospitals, Financial Assistance, Medical Bill Reimbursement. Delegate Charkoudian, and then we do have a couple panels on this bill. Delegate Charkoudian, welcome.
Thank you, Madam Chair. Members of the committee, for the record, Delegate Lord Charkoudian here requesting a favorable report on House Bill 694. And let me begin by saying, thanking all of you for the extraordinary work that you have done over the last few years on hospital debt issues. And in particular, in the 2020 session, you passed Delegate Lewis's bill. We all passed it, but it came out of this committee. You did the work. House Bill 1420. And part of what that bill did is it required the HSCRC to do an analysis to really look at a number of issues related to free and reduced cost care. There were a lot of really important things in that analysis. The report came out, you may recall, last February. A lot of really important pieces of information there, and it really sets us up well to do some additional policy work in this area. But one part of it in particular was particularly troubling. And that was that what this found was that in 2017 and in 2018, both years, there are approximately $60 million each year, so total of $120 million, that the hospitals collected from people who were eligible for free care. So that's separate from the fact that 60% of the people in this data set that was looked at, the hospitals actually pursued for debt and never were able to collect. But what this means is that this $60 million, there were roughly 120,000 people whom the hospitals billed, who should have been screened and received free care. And those individuals, presumably not knowing they were eligible for free care, paid that bill. Now, to be fair, the report was not designed to identify all of these individuals. The report was designed to see what was going on in the world of free care, payments, medical debt, and so on. But once this information is out there, I think it is incumbent on us. I think it is crucial that we as policymakers act. It is not okay for us to say, oh, in those 2 years, it looks like, and potentially other years, hospitals collected this money from people who were eligible for free care. And that's okay, we'll just keep going. And so what my bill attempts to do is to take a look at, with any of the data that we have the ability to get our hands on, and I'll talk about the details in a moment, we want to do outreach to these individuals, tell them that they were eligible for free care, probably eligible for free care, and that they can contact the hospital and request a reimbursement. And the bill requires that the hospital provide that reimbursement. There's a lot of details on how we propose to do that. It's a communication and coordination between HSCRC and the Comptroller's Office primarily, as well as some work with the Department of Human Services. Spent a lot of time in the fall working with HSCRC and the Comptroller's Office to make sure that this system was doable. Again, because the report wasn't designed to find a way to do the reimbursement, because that's not what we thought we were going to do. But once we found this really problematic outcome, then it was necessary to look at the data that was available and figure out, okay, how can we get information to these individuals, let them know they shouldn't have paid if they did pay, and make sure that they can get their reimbursement. The payments range from, could range anywhere from $60 to several $100s. But it appears from the data set that several of these individuals actually were treated in the hospital several times in those periods. And so it's possible that any of these individuals may have paid several $100s. And these are individuals who are eligible for free care. And so the reimbursement of several $100s, even 5 years later, really can make a big difference in their ability to make ends meet. We have a number of people who are going to testify on this, and we can take questions, but I'll just say, I have also been speaking with the Hospital Association about this bill. I think they'll share that, they don't believe that it was intentional to not find these people eligible and to bill them. And so with that in mind, I think we're working in good faith to make sure that the hospitals are positioned to work with HSCRC and the comptroller's office and make these reimbursements. I thank you for your time, and I look forward to questions or discussion.
Thank you so much, Delegate. We have 5 panelists signed up as proponents, and then we will have 3 favorable with amendments on a second panel, which is coming up after this. So let's hear first from Victoria Neflin.
Good afternoon, and thank you for giving me the opportunity to share my story with you all. My name is Tori. I'm 23 years old. I'm from Westminster. I'm a recent cancer survivor and a patient advocate. My medical debt story isn't all that uncommon. I was 22, I just graduated college and was accepted into AmeriCorps and CCC. Then shortly after moving out to Iowa to begin my service year, I accidentally stumbled on a cancer diagnosis and was launched headfirst into the world of medical debt. In my work as a patient advocate, I've seen this story time and time again. An average household, lower middle class, making enough to get by, but not so much that they could handle a large unforeseen bill, mixed with an unexpected diagnosis, a complicated hospital billing system, and suddenly you find yourself drowning in debt with no end in sight. It's my story, but it's also the story of so many patients just like me. But it shouldn't have to be this way. Hospitals have the ability to offer patients free and reduced cost care, and in fact, they are legally required to do so, but instead, they've pocketed these tens of millions of dollars earmarked for us and left us to suffer in agony, because that's what it's like to live under the weight of crippling medical debt. It's agony that compounds on the agony and suffering we're already experiencing physically. It was hard enough to undergo a transplant with a 1 in 5 mortality rate, a traumatizing fertility preservation process, months of chemo and transfusions, a session of radiation that quite literally almost killed me, and to spend a year of my life living in a constant state of nausea, sleeplessness, pain, and fatigue. But to have to do so while desperately fundraising for my transplant on GoFundMe, while applying for grants and assistance that almost never came, while watching my mother and sisters give up everything to support me, that was soul crushing. House Bill 694 is the very least hospitals could do to atone for the millions they stole from us during the worst moments we've ever been through. I only hope that in the future, they also stop stealing this money from us in the first place. Thank you.
Thank you so much for your testimony. Next up, we have Brig Dumais.
My name is Bridge Dumais. I'm with 1199 SEIU. We represent over 10,000 healthcare workers in the region. Our union supports HB 694 and urges the committee to vote favorably with no weakening amendments. A major barrier for patients seeking care is whether it's affordable. Healthcare workers see many patients delay care because they can't risk medical debt. That unfair choice makes patients' health deteriorate long-term, and the more severe a patient's condition becomes, the higher their medical bill will ultimately be. What makes this predicament even worse is that many healthcare workers themselves are delaying care or accumulating medical debt. One 1199 member shared that her health insurance does not cover her insulin, so her diabetes has gone untreated for 4 months. If healthcare workers cannot receive care themselves, everyone's health is at risk. 1199 members at the bargaining table with hospitals have seen that management often cares more about protecting their bottom line than patients and workers. Because 1199 members are unionized, they have bargaining power to fight back. Hospital patients, on the other hand, do not. This bill rectifies the power imbalance between management and patients. If hospitals are required to reimburse those who were supposed to get free care, it incentivizes them to stop systemic overbilling and provide greater transparency on debt collection. This bill creates much needed accountability for hospital management. Hospitals charging free care eligible patients 60% of the time is morally outrageous, a betrayal of their charitable mission as nonprofits, and a failure to meet their legal obligations. This bill makes patients whole by returning the money hospitals stole from them. 1199 supports the sponsor amendments and urges a favorable report on HB 694 with no amendments that weaken the bill. Thank you.
Thank you very much. Next up, we have Aja Mallory. Or Aja, I'm sorry.
Madam Chair, members of the committee, my name is Asia Mallory. I'm a consumer staff attorney at the Maryland Volunteer Lawyer Service, where we connect volunteer attorneys to low-income Marylanders. 30% of our clients that seek a bankruptcy assistance state medical debt as a significant fact. I operate a weekly consumer protection clinic at the district court, and nearly everyone we meet at the courthouse who is being sued for medical debt would qualify for financial assistance. 200% of the federal poverty level matches MBLS guidelines for legal assistance. A family of one can earn up to $27,000, and a family of four can earn up to a little over $55,000. If a person qualifies for MBLS's legal assistance, they should have received free or reduced cost care from the hospitals. The average consumer that we see at these consumer protection clinics is an African-American woman earning under $30,000 Maryland median income. She's in her early 40s, she doesn't have a college degree, and she's caring for at least one parent or one child at home. Most of these people who are being sued for debt collection, they don't receive the type of legal assistance that we provide at the district court. So these debt collection suits often result in wage garnishments, and a loss of 25% of their income results in a cycle of debt for them. In these cases, they cannot assert that they should have received free or reduced cost care from hospitals in these medical debt lawsuits. Therefore, they often rely on us to get postponements in the courthouses just so we can get them access to these financial assistance applications. So reviewing patients for medical financial assistance prior to sending them to collections is very necessary. Patients who paid these medical debts or were garnished by the hospitals deserve to be repaid. My clients often choose to forego basic necessities in order to pay their medical debts. And that's not something that patients or my clients should have to decide. Consequently, we urge a favorable report for HB 694. Thank you for this opportunity to testify.
Thank you so much, Asia Mallory. I promise to get it right next time. Next, we have Marceline White.
Sorry, you think I'd know by now. Good afternoon. My name is Marceline White. I am the Executive Director of the Maryland Consumer Rights Coalition, MCRC. MCRC advances economic rights and equity through research, education, direct service, and policy advocacy. And we're here in strong support of House Bill 694. And I want to thank Delegate Charkoudian for introducing it. I just want to take a few minutes. My colleagues have talked a little bit about why this is needed. I just want to take a few minutes to focus on some of the concerns we have. We think this is important because it addresses current problems in the Maryland hospital system. Regardless of why this happened, the fact is 60% of patients who should have gotten free care were instead sent to debt collection. And of those, 1% paid $120 million instead of getting free care. So, you know, why it happened needs to be resolved in other legislation and in more work built on the good work this committee has done. But this bill resolves the issue by making these patients whole. You know, particularly because these hospitals were already prepaid by the state of Maryland and then paid again by these low-income consumers. It's needed, as you've heard from my other colleagues, and based on my testimony about our Medical Debt Freedom Fund, we found 73% of people coming to us for support for our Freedom Fund had hospital bills and should have qualified for free care. One thing we want to emphasize is that we need to do this now. We do not need to delay, and we need to be looking forward to implementing the legislation and the set of studies now and going forward that reflect the hours of the middle of the pandemic. I also just want to note that a single point of contact is important. If you look at the mortgage crisis that many of you lived through and legislated through, we know that having a single point of contact that people can go to is critically important as well. Otherwise, they often get lost in telling their story again and again to different people, as you heard from my colleagues. So we think the bill is critically important. We think the time is now to hold this accountability and work together to do better in the future. And for all of those reasons, we support House Bill 694 and ask for a favorable report. And of course, I'm happy to stay here and answer questions.
We have one more panelist before we go to questions. We already have some questions. Next up is Ashley Black.
Yes, good afternoon, committee. My name is Ashley Black. I lead the Access to Health and Public Benefits project at the Public Justice Center. We strongly support House Bill 694 as a means of addressing an egregious wrong against Maryland patients that resulted from hospitals failing to meet their obligations to provide charity care to eligible patients. A snapshot of medical debt nationally shows that communities of color and low-income patients are disproportionately impacted. This holds true as well in Maryland, where we see gender, race, and income disparities in medical debt as lawsuits are filed disproportionately against women, people of color, and low-income individuals. Last year's legislation, the Medical Debt Protection Act, sought to address these inequities by putting in place much-needed protections in the collection process for patients. House Bill 694 complements the Medical Debt Protection Act by putting money back in the hands of patients who should have received free care but fell through the cracks. Collaboration between not only HSCRC and the Comptroller's Office but also DHS is essential to identifying every Marylander who should have received free care in 2017 and 2018 but paid their bill. DHS, as we know, touches the lives of many of Maryland's lowest income residents. These are individuals who are struggling to make ends meet and may be receiving public benefits like SNAP or temporary disability assistance to keep their households afloat. Trying to pay off a hospital bill that they never should have received may have been financially devastating for some of these families and put them in a position of having to go without basic necessities. Receiving this refund could be transformative for many of these families. This approach is also consistent with previous health equity legislation that this committee has passed. House Bill 694 pushes our hospitals to meet their obligation to provide charity care to those who qualify and ensuring that no Marylander is billed for hospital services when they shouldn't be. Thank you, and we urge a favorable report.
Thank you so much. We do have a number of questions from the committee. Let's hear from Delegate Chisholm first.
Thank you, Madam Chair. I was reading the letter, and in the letter, the HSCRC acknowledges that the patient must tell the hospital that they would like financial assistance. And maybe there's a communication breakdown, because it would be in the hospital's best interest to let them know about that and try and help them. But at some point, if the hospital doesn't know that somebody wants financial assistance, how do they go about this? And when does it become the patient's responsibility or the patient's family's responsibility to tell the hospital, I want financial assistance? I just don't understand the communication breakdown, one. And number two, what else can we do? Or what else can the hospitals do to make sure that this is communicated from the patient to the hospital and I guess vice versa?
Is that a question for me? Do you want me to take that, Madam Chair? Or
sure, if that works for you, great.
Okay, yeah. Thank you for the question. I think the reality is that patients need to know that they can ask for free care, right? So your average person who hopefully doesn't go to the hospital that often, but maybe does, especially once they have an illness that they're treating. But when they begin engaging with that hospital, doesn't necessarily know what the income levels are, how to ask for free care, so on and so forth. So it is absolutely on the hospital to communicate that free care is available, to screen for the possibility of free care, to screen for the possibility of enrolling in Medicaid. One of the things that we have done, the General Assembly has done over the last 2 years, is really strengthen the way that we make sure hospitals are doing that. And so my bill last year, the Medical Debt Protection Act, and Delegate Lewis's bill the year before, strengthen that requirements on the hospital to make sure they're communicating that, and then also add additional protections so that people are offered payment plans if they're eligible for reduced cost care, so that before any lawsuits are filed, there has to be this double checking to see if they were eligible for free care. But what we know from this study is that for whatever reason, that was not done. And I would say the hospitals dropped the ball to some extent. So that's why now they have the obligation, and we will support that effort with this legislation, to find a way to make these folks whole. I think making it clear that the General Assembly takes this obligation to make sure free care is provided seriously and to fix essentially 2017, 2018, and depending on what we find happens with those years, what the bill does is if 5% of folks end up with a reimbursement, then the process repeats itself for 2019, 20, and 21. Our hope is that the bills that we passed last year and the year before ensure that the message is getting sent to people, and so they have so people who are eligible know that they can apply. But we still have this problem of the last several years. We have reason to believe that that wasn't done as well as it should have been done. And so this repairs that harm.
Thank you, Delegate. Thank you, Madam Chair.
Thank you so much. Delegate Kipke.
Thank you, Madam Chairman. I have a bunch of questions, but I know I'm limited to how many I can ask. To the bill sponsor, it seems like this bill sort of came out of that HSCRC review that was done a while back. And I hope you've been able to look at the letter that they've submitted for today. I'm looking at it now. In the letter, it says that if this bill is passed, a number of operational and analytical challenges that may prohibit implementation. I mean, that kind of seems to me like it's saying like this isn't going to work. So I guess could you respond to that? I'm sure you've been working on this. I heard you say that for a while. It just seems to me that there may be some problems with implementing this. Just want to get you on, if you could provide some clarity as to what you think about that.
Yeah, thank you. I'd be happy to do that. So I think, first, let me just be clear. I have looked at that letter very carefully, and I have spent several hours actually in conversation with HSCRC to craft the bill. I would say there's still a handful of things that we still need to perfect in the bill, and I think that's really what it is that HSCRC is highlighting. I think that the important thing that they're trying to highlight is that they didn't do the study to set up a reimbursement. And that's a really fair statement to make. And so what they're saying is if we were doing a study to set up a reimbursement, we would have done it differently. We did this study to understand what was going on with free and reduced cost care. Okay, so understanding that, we actually have two choices as a General Assembly. We should be morally outraged about the results of the study. And so we can either say, okay, we'll start again and do a whole new study that's based on how to reimburse, and then we'll reimburse folks based on that study. Or we can say, granted that this is a somewhat flawed way to start, let's take all the data that we have in this study. Let's take the data we have in the comptroller's office. Let's take the data we have in the Department of Human Services, and let's do the best we can to match all that data and get as much of those reimbursements done as possible. And that seemed to me to be the more efficient way to go. So even though it's not perfect, it's more efficient, and it leads us to the possibility of being able to make those reimbursements. So without going through every single point that's made in the HSCRC letter, I would say I have either prepared or in the process of preparing amendments that address most of their points. And you could actually speak to them. I think that they would share with you that they really did work very closely with me in putting the bill as it was together, but ultimately I had to put it into drafting, so I didn't get to go through all of the issues.
Thank you. Just a quick public service announcement. I think her name was Dumais, made a mention about trouble getting diabetic treatment. And I want to make sure people know at insulinhelp.org, there's great resources there. So please share that with your member. Thank you, Madam Chairman.
Absolutely. Delegate Lewis Young.
Thank you, Madam Chair. I'd like to follow up on this single point of contact issue, and I'll address it to the sponsor, and you can defer to someone else if you choose. The Hospital Association made a number of amendments, specifically number 8. I'd like to know what you think about that recommendation, striking having an individual or a specific person responsible, and instead having the hospital billing department be listed?
Yeah, thank you for that question. Let me say, thank the hospitals for sharing some of their amendments with me in advance. So I did have a chance to look over them, and that is one of the ones that I am very concerned about. When we saw that, I asked my intern to call all the hospital billing departments in the state, just to, go through online and find the hospital billing departments and call them and just see how hard or easy it was to get somebody on the phone. And I don't have my data in front of me, but close to half of them, it was very difficult to get somebody on the phone. And some of them, she waited for 20 minutes on hold, and others she called 3 or 4 times throughout the day and couldn't get through to somebody. And then there were others that were fantastic. They answered the phone right away. They talked about how they could be helpful. But there were enough that, and I think, most of us have these experiences of, trying to get through to the standard billing department and spending a really long time doing that. There were enough that I think that's not an acceptable solution. So there may be other possibilities that we can talk about, but that the billing department is not an acceptable solution. And frankly, those outcomes, which I've communicated to the hospital association, raise concerns about a whole host of other things, like we're talking about payment plans, and we have policies about payment plans. And if someone were to need to call the billing department to set up a payment plan, similarly can't get through to someone. And again, really important to remember that if we're talking about low-income individuals, if we're talking about people who work hourly jobs, shift jobs, that any time they're spending on hold trying to get through to somebody is time that they're not getting paid for. If they're only available 9 to 5, all of that creates additional barriers. And the other thing I just want to say about that, of course, is that in addition to those particular individuals who might try to call and get paid, get their repayment, because this bill has a threshold of the number of people who need to be, repaid for the next 3 years, to do this again for the next 3 years. If the vast majority of people trying to call can't get through, then of course we're going to have a very low rate of return, and that'll also then affect our ability to do it for the next 3 years.
Okay, thank you for that. Perhaps it sounded a bit better than reality would suggest.
Thank you.
Delegate Krebs, followed by Delegate Kerr. Delegate Krebs.
Thank you, Madam Chair. This is probably one of the most complicated issues we've had in front of us this year. And you start off by saying that the report that this came from was a flawed way to start. It's not perfect, but it's more efficient. So my question, given the 5-page HSCRC letter, which for your information, I think is very, very well constructed, just with giving us information, how do you justify, we got the $60 million figure, and basically in their report, it says, well, I'm not going to go through the whole report, but how did you justify coming out with this method of reimbursement for people who have already paid from 5 years ago? What was the impetus for this, and how is this the right solution to this problem? Or I say it's a problem. No one on here is actually said that they've been wronged by this and they want restitution. It's you saying we need to fix this problem. So given all of that, how does this committee move forward with this very, very complicated and hard to implement legislation?
So there's a lot of questions in there. I'll try to be efficient.
I'm sorry, but there's a lot of questions. I'm only able to ask one, so I'm putting them all in one question.
Part A, B, C, D, and E. Fair enough. Okay, so here we go. Let me start with the first one. Is there a problem? Yeah, I would say we have a moral obligation as a General Assembly when we see that we have established a system that people who are below a certain income are supposed to receive free care, and we find out that 120,000 of them in 2 years in a row, that $60 million worth of that free care was not offered. So that's the first problem, is we have a moral obligation to act on that. So once we recognize that, then the question is, how should we act? So one way to act might have been to have come in and said, okay, let's spend another $500,000, $750,000, and get HSCRC to do another analysis to figure out exactly who those people are, figure out how to pay them back, etc. Or what I did was I started with what we had, sat down with HSCRC first. I said, walk me through the data and what you have here. Then I brought in the comptroller's office, because the comptroller was the one who did the matching. And I said, walk me through what you have and how you're pulling this off. And then I brought in DHS and I said, walk me through what your part would look like on this. And with all of those people together, we figured out what it is that we have in this system, which is they take the de-identified information, they connect it to the comptroller. The comptroller is able to connect it to a person. The comptroller can see what the income level is for that person and can see that as long as they don't also have assets based on that income, they definitely were eligible. And then they can send the letter saying, it appears you paid a bill, it appears you're eligible, contact the hospital. Now they could contact the hospital and find out they had assets and so they weren't eligible, but we expect the vast majority of folks who are earning below that threshold to not also have assets that would make them ineligible, but that is the piece they have to check for. So we spent a lot of time really thinking about, with the data we have, because we're going to ask the hospitals to pay the cost for this, do we want to do another $1 million study that gets us perfection and then go through the payment? Or should we take what we have and for, I think it's like 250,000 or something, or 200,000 ends up being, to run the process, this second round of processes, and do our best with this efficiently, lower cost, get the vast majority of these folks a reimbursement, which we believe that this could do. I think the bigger challenge is going to be if we can contact them, like if their addresses are still good. I think that's going to be the bigger challenge than the rest of the data matching and those kinds of things. So I think that unless, I mean, if this committee felt like it was more appropriate to start from scratch, you know, do $1 million study that starts with the idea of let's identify the folks and get them their money back. I mean, I would be open to that, but given where we are, I think, and our moral obligation to act, I think this is sort of the best that we can do.
Thank you so much. Delegate Krebs, I'm just going to remind the committee, we have 30 witnesses left today. And there's 3 more panelists on this bill. If you have a quick follow-up, we can do it. I just want to make sure.
Just a quick question. The quick question is, why just those 2 years of 17 and 18? Why not 15? And you can answer this later. And then why not 19, 20, 21? And you know, why
and
these two particular?
Can we do the answer in like 3 sentences?
You can do the answer in subcommittee. Just it's a question I'll have.
Okay. Those are the data. That's what that's the years they did the research on. So that's what we have right now.
Thank you. Okay, Delegate Kerr.
Thank you, Madam Chair. Delegate Charkoudian, I'd like to get back to the HSCRC letter, specifically their concerns about data privacy. This is actually a point that Delegate Hill brought up on a bill earlier today. So with all this tax information and hospitalization data being used by so many agencies, have you sought or have you gotten a legal opinion on whether this bill violates any state or federal laws, HIPAA laws, other protected privacy rights?
Yes, and in fact, one of the amendments that is a sponsor amendment is I worked with I worked with the Attorney General's office, and we're going to shift it from being postcards to being mailed like in an envelope. So that addresses the privacy issue. So I've been working with the Attorney General's office on this, and I believe that addresses the issue.
Thank you, Madam Chair.
Absolutely. Delegate Hill.
Thank you. Thank you, Delegate Charkoudian, for doing all the work on this bill. Can you let us know, are your amendments going to address A, B, and C? A, what happens if someone qualifies for reimbursement and they don't accept it, or they've passed, or they're no longer available? What happens to that money? Number 2, does the hospital get to revise their uncompensated care numbers for those years and then come back to the state and say, we did this much charity work and now we want to get reimbursed by the state? Because I don't see a provision to protect the state from having to pay the hospitals for that. And is there an appeal process if the person goes saying, look, I got this notice, and the hospital reviews everything, says, no, actually you didn't qualify? Is there an appeals process? So I'm asking if you have amendments for those things. Thank you.
Those are great questions. And I think the short answer is no, but I'm happy to address them in amendments if you have suggestions on how to do that.
Thank you so much. Delegate Morgan.
I believe my question was just answered. Thank you.
Perfect. So I see no more questions from the committee for this panel, but we do have a favorable with amendments panel. Let's hear first from Nicole Stallings.
Great.
Thank you, Madam Chair. For the record, Nicole Stallings here on behalf of the Maryland Hospital Association, favorable with amendments on House Bill 694. First, I want to thank Delegate Charkoudian for meeting with us on the bill. We've been at the table from day one with a very clear position. If a patient was billed and later found to be eligible for free care, we agree that a refund should be provided. In fact, Maryland law already requires this within a 2-year window. And so while this bill looks at care provided 5 years ago, we do agree that a refund should be provided for any out-of-pocket payments. Our hospitals believe that every person should receive care that they need without financial worry or hardship. Our hospitals make every effort to inform patients about available financial assistance. That includes free or reduced cost care, helping patients enroll in Medicaid or other insurance options, and sets up reasonable payment plans when needed. And that process doesn't work perfectly every time. And we've been in front of this committee numerous times over the past 2 sessions. This body strengthened the state's already robust hospital financial assistance laws by passing comprehensive reforms in 2020 and again in 2021. And these reforms have been in effect for less than 2 years, and our hospitals have been working diligently during the pandemic to ensure timely implementation. But this legislation goes even further, and yes, there are many unknowns and assumptions and operational issues that need to be worked through that are outlined in the HSCRC letter, and my colleague will speak to momentarily. But let me conclude where I began. Our hospitals support the intent of this bill. If a patient was billed for services when they were eligible for free care, it was done unknowingly. Our proposed amendments address some of the operational concerns with the bill, and we look forward to ongoing discussions with the sponsor. We urge a favorable report with amendments. Thank you.
Very much. Next, we have Brett McCone.
Thank you, Madam Chair and committee members. Brett McCone from the Maryland Hospital Association. You just heard from Nicole on our overarching consideration. You know, we've agreed that if we've inadvertently collected an amount from someone eligible, we should issue a refund. But I'll share some additional considerations and the rationale for the proposed amendments. First, we suggested throughout the bill that you add the words "you may" before have been eligible for free care for several reasons. First, and I want to make this very clear about this $60 million amount. The HSCRC clearly acknowledges in their letter that the data that they use, this was for policy estimates. And there's a number of assumptions built into those policy estimates. The HSCRC cannot know with certainty that any account, what was paid on any account without having that billing record. And it was impossible to know the patient was eligible for free care without income documentation prior to gathering this information from the comptroller's office. This is data that hospitals nor the HSCRC don't have access to. And they're very clear on page 2 that they believe that this amount is likely lower than $60 million. Second, and for that reason, the hospital should be penalized under this subtitle because we don't have that blanket access to tax return data to verify incomes. And as noted earlier today, that if the patients don't respond and provide that information, we have no way of knowing that. Third, again, HSCRC's letter on page 4, there are some privacy concerns. You heard about that earlier. More generally, at some point, even with these safeguards in place, tax return data pass back and forth with protected health information. And finally, given the concerns about the operational and analytical challenges, we ask that instead of the automatic trigger that the HSCRC report its findings before the 19-20-21 be completed. We worked openly with the bill sponsor, including reviewing HSCRC's concerns. They had 2 letters they shared. And as such, we offered our amendments to make the bill operationally feasible, a fair and reasonable outcome for everyone. And again, if we unknowingly collected money from folks who are eligible, we want to be clear that we want to address that. Thank you very much. And with our proposed amendments, we ask for a favorable report.
Thank you. And final favorable with amendments is Pat O'Connor. I believe Pat is here. I am not seeing or hearing Pat, so she must have stepped away. Why don't we go to questions? We do have a question from Delegate. You are here. Pat, go ahead. Pat, I see you. I think you're on mute.
Hello?
There we are. Thank you.
All right, fantastic. I don't know why there was a problem. It's so good to see you all, and we're so happy to be here in full support of this bill. Pat O'Connor, here for the Consumer Protection Division and the Health Education Advocacy Unit of the Office of the Attorney General. We consider a reimbursement mechanism like the one proposed by this bill to be essential to making the tax exempt schemes under state and federal law work for consumers as well as hospitals. To remind the committee, hospitals are tax exempt under state and federal law in exchange for their legal obligation to provide free care to Marylanders who earn 200% federal poverty level or less. There has been a chronic problem in enforcing this obligation. And the report issued by HSCRC finally gave us an idea of the scope of what is happening in our marketplace. If you assume that the $120 million is accurate, what that means is that the hospitals kept their tax savings that were supposed to be used for that free care. They've had the use of that money since they did not spend it on that free care. Plus, they collected money from people who were eligible for the free care. The beauty of this bill is it shifts to the hospital the expenses and, yes, some administrative difficulty in correcting this serious wrong. We believe it is vitally important because of the advantages enjoyed by hospitals combined with the disadvantages of patients when they are in the system. As our first advocate explained, when you are the patient, it is very difficult to handle the business issues associated with your care. In addition, there is not always full disclosure by the hospitals at the right times, in the right ways about the availability of financial assistance. With this mechanism, there will be a way where the hospitals police themselves and consumers have a meaningful way of being sure they first receive the care they're entitled to, and second, that they're not effectively double billed by paying out of pocket for something they should never have been billed for.
Thank you so much for your testimony. And so just to be clear, you are signed up favorable with amendments, but you're referring to the sponsor amendments on the bill.
Yes, we put in the amendment to protect the confidentiality of the sensitive financial and health information by requiring a letter in a sealed envelope. We'll be happy to work with some of the other stakeholders who have commented on some additional privacy and confidentiality concerns. We're always very, very attuned to those, and we'll work with the sponsor and others on those and other issues. We really think we need this.
Thank you so much. We have two questions. Delegate Carr.
Thank you, Madam Chair. My question is for MHA, and the question is, it's a two-part question. How will patients benefit from the removal of DHS from the process? And what's your plan to provide refunds to patients who do not file taxes?
So Delegate, I'll take a stab at that. We do have an amendment seeking the removal of DHS for this particular pilot. And the HSCRC letter also notes that they are unclear how DHS would be able to participate in the program. So we believe it adds a lot of complexity right now for something that we are willing to test, willing to try out for these 2 years. We believe we should start with the Office of the Comptroller where it's cleaner. With respect to individuals who don't have tax information, I think that's another unknown. I noted there many unknowns, assumptions that need to be worked through. All I can say is we're committed to being part of that process, being part of the table with the state agencies, with the sponsor to see how we can move this forward. But we do believe, since this is something that we are testing, we should do it in a very measured and deliberate way so that we can ensure we're taking the right steps to get this right.
Thank you. Delegate Kipke.
Thank you, Madam Chairman. For MHA, it seems to me that since you do not have, per your testimony, and quite obviously, the tax information, the income information for individuals who come through the hospitals, I'm thinking that there will never be like a perfect way to prevent this from happening in an ongoing fashion, because it ultimately rests with the patient. And my question is, I vaguely remember, and I don't remember if it was Delegate Lewis Young or Delegate Charkoudian's bill, but I recall there being an effort to ensure that before someone goes to collections, that they be given, clear, you may be eligible for this, you may be eligible for that. I believe we put that into law. So can you remind the committee about what's in place currently that that this legislature passed to guard against some of these things? And if you could just speak, ultimately, it doesn't this just rest with that individual? Yeah, that's it. Thanks.
Sure, happy to respond to that. Thank you, Delegate Kipke. Yes, we have, there's been additional legislation, and that's on page 2 of the HSCRC's letter, noting that there are additional notifications that have been put in place before the additional measures. In addition, back to Ms. O'Connor's comments, every single billing statement that goes out from every hospital in Maryland is required to have the words, "You may be eligible for free or reduced care, and please contact the hospital." So every single statement, patients typically get between 4 to 6 statements before there's collection action follow-up. So there is, there is awareness. To Delegate Kipke's point, we don't have access to this type of information, to this type of income information. And the reason that the report was developed is because the HSCRC had to find some source of information, because unless it was provided by the patient, the hospital has no way of actually knowing whether or not the patient is eligible. We certainly provide, all of the opportunities, and we want to provide free and reduced care to folks. But the fact of the matter is, we do not have access to this information. If we did have access to blanket tax information, it would be a much easier process for us to identify who was eligible for free or reduced care. So this is a big challenge. HSCRC does acknowledge this, and very clearly that hospitals do not have access to the patient's incomes for purposes determining patient eligibility. And the HSCRC did not during this process either. So, there's still the fact of the estimate in this report.
Thank you.
Thank you. Delegate Saab.
Thank you, Madam Chairman. I'm sorry, I might have missed a part of the beginning of the bill, but I'm looking at the bill here just to make sure I understand it correctly. So the way I read it quickly, does it say that, so we have to look back to 2017 and 18 to see who would have qualified for this bill? And then if we find 5% of the people that would have qualified, then we extend it to 19, 20, and 21. So that's one question. And then why 5%? I guess where did the number come from? Because I see 5% in a couple places. I see it here, and I also see it in one section when it says that it has to be also sent to 5% of non-English speaking population. So what are those, what do you have any idea what are those languages also? Thank you.
So we have whoever wants to answer. If someone wants to answer, go for it.
Sure, thank you, Delegate. Madam Chair, on the 5% of the language, that's standard. That is that parallels other things where we have to provide notification in with the same documentation. I think on the 5%, right? There's questions about that, whether that's 5% of the people who actually receive postcards contact the hospital, or whether it's the patient's actually receiving refunds. Because again, we don't know whether or not, even if the patients believe that they're eligible, whether or not they actually paid anything on those bills. I think the 5%, I mean, I do think that would be a question for the sponsor. I think that was written into the language as far as the triggering mechanism. The other piece was the reimbursement for the agencies. But the 5%, I believe was picked given that our position, and the reason that we offered an amendment to look at the study is because based on the HSCRC's analysis and the fact that they, like us, believe that there will be far less than $60 million in refunds now, are looking at what that amount would be, and should we look at that before we automatically expand it to 19, 20, and 21.
Thank you.
Absolutely. Final question is from Delegate Hill.
Thank you. Mr. McCone, I'm not on the subcommittee, so I just needed some clarification. I understand that the hospitals don't have, blanket access to tax and income information, but when you said we don't have access, were you implying that the hospitals never ask people who come to them and inquire about whether they're eligible to present tax documents, so you never see them? Or that it is, the default is you don't and people have to present it to you? I just want to be clear what the practice is.
Very good question, Delegate Hill. Thank you very much for asking. I'm sorry if that wasn't clear. No, absolutely. During the financial assistance process, we ask people for the information, and we certainly try and sit down with everyone, particularly those that are uninsured. Obviously, that's our first. We want to make sure we gather their information. Number one, to try and get them insurance and try and get them qualified. We look at income documentation, and we want to understand that for purposes of financial assistance. So yes, we are asking for that.
Good. Okay, one more question from Delegate Bandari.
Thank you, Madam Chair. Thank you, Ms. Braid, for your willingness to correct whatever was wrongfully charged for these low-income patients. In your testimony, you said that the patient benefits information was not up to date when it was initially captured. Are you sure that, when you guys collected too much, there was not any error in the billing process? Were they overpaid by mistake, or they were out of fear they did that, resulted in the wrongfully charged for care? And one more thing that I think there must be a system of collecting the money, either digital payment options or something. And you were saying that we don't have any way of knowing or collecting the data, something. Could you please clarify on that, Britt?
Sure. Thank you for that question, Delegate. Let me start with it and work my way backwards. We don't have a way of getting the documented income or the assets unless the patient provides that information to us. So when I said that information is not available, we certainly, to Delegate Hill's question just a second ago, during the financial assistance process, we work with the patients to ask them for income documentation and income verification. So we understand where they are, because we want to be able to provide the financial assistance or charity care to them. And so, we work through that process. Whatever the second piece from the billing perspective, however they paid the bill, I mean, we can refund the bill. But again, the question, and back to what the HSCRC said, we don't know without going into each individual billing record whether or not the patient paid any amount on that bill. What was done by the commission was a number of estimates based on the average amount of out-of-pocket costs and what they believed that the tax documentation showed for this population. But there is no way to know with certainty how that matched up unless they go to Brett McCone's record and say that, okay, I see here there was a remittance of this, and he, from the comptroller's records, had an income less than 200% of federal poverty level. There is no way to know that, because the data that was done and used for this study does not capture that.
Thank you.
Excellent. I see no more questions from the committee on this bill. So with that, we're going to conclude the hearing on House Bill 694. Thank you to everyone for your participation in this hearing. Great news for the committee. Delegate Pena Melnick has been sprung from judiciary, so she will be taking over chairing the hearings. However, first, we will have our regular afternoon break. So it is 3:18. Let's go ahead and round up to 3:20 and say we will be back at 3:35, starting the last 4 bills. And there are 30 witnesses on those 4 bills. So we will break now and return at 3:35. Thank you.
Okay, good afternoon. Good afternoon, everyone. I want to take a minute just to thank Delegate Kelly for helping me out this afternoon. I really appreciate it. And thank you all for coming back in a timely fashion. We appreciate it. So next, we have House Bill 715, which is Delegate Valentino Smith. Administrative Services Organizations, Requirements for Retraction, Repayment, or Mitigation of Claims. Good afternoon, Delegate Valentino Smith. You have 5 minutes. Welcome to our committee.
Thank you.
Our pleasure.
I like to move through this as quickly as I can with that clock running, so I'll stick to my script. Unfortunately, you're all too familiar with the shortcomings of Optum. Optum went live on January 1st, 2020, and since then they've been completely unable to process and pay for their claims, and they have failed to provide reasonable claims form data in order for the providers to efficiently and accurately reconcile their claims. For almost 2 years, the department and Optum have been promising a functioning claim system, and you all have been involved in numerous status briefings where they have created the impression that a fix was on its way and right around the corner, only to hear from the providers that Optum did not meet the deadlines we were told they would meet, and that they continue to ignore proof presented by the providers that their systems continue to operate with great dysfunction with respect to two things: dysfunction with respect to the reconciliation of the estimated payments, and for the real-time claims that they are now processing, which they undertook after the estimated payments. Optum's written testimony states that because they're processing 99.4% of the claims in 14 days, the legislation is not needed. You will hear from the providers that the processing in 14 days in no way represents the amount of denials, disputes, and reprocessed claims. So they're doing a really fast and speedy job to do a bad job. House Bill 15 will do the following and why it's needed. It requires Optum to meet certain requirements, just the industry standards, before it can begin to retract or require repayment for claims submitted with the dates of service during the estimated payment period. If Optum's unable to comply with the industry standard requirements, they must, at their own expense, retain an independent auditor to determine, with input from affected providers, any amounts owed by providers. Providers can request an independent auditor at Optum's expense to resolve differences regarding amounts owed, following reasonable efforts to work with Optum. And it requires MDH to continue to give us reports no later than 30 days after this on the status of the estimated payments and the claims submitted. The bill sunsets in 2 years. You've seen concern raised as the bill's written that it's unconstitutional in application. I've reviewed the concerns with the Attorney General's office. I'm submitting an amendment that removes the sunset and provides for application of this bill to apply to any other similarly situated administrative service provider. I firmly believe the amendments completely remove the constitutional concerns. The crossfire was heard in the Senate, so I know what Optum's going to say. They're going to say they're finally able to provide the 835 forms. You'll hear testimony that they found a new tool and new data reports days before the Senate hearing that are carrying everything. Given that Optum believes that the bill is not needed, I really want to quickly run through. 29 days ago, on January 31st, you all received and we received from the department an update to the Joint Tamarins report. It's painful. Optum has failed to deliver a comprehensive reporting system as defined in the contract. The current reports are limited in nature, and specific reports are only produced by request and on an ad hoc basis. The MDH Office of Internal Controls and Audit Compliance found that Optum systems are deficient and in need of stabilization. This is 29 days ago. MDH has 4 main contract management tools with the contract: service level agreements, liquidated damages, and withholds. Since the contract started, MDH has withheld only 4% for failing to meet. They failed to meet 11 of the 12 service levels. The only service level that they're meeting in the contract is the requisite number of staffing. They continue to track process failing in their root cause analysis, and they put CMS on notice. Just 30 days ago, in this JCR report, the department stated that Optum has failed to deliver a comprehensive reporting system as defined in the contract. The current reports are limited in nature and specific reports are only produced by request. Look, I'm running out of time. We had a big budget hearing. I can't cover that now, but I'm submitting it to you and can talk to the subcommittee. We gave them $1 billion and estimated payments were sent out. 80% went out during the pandemic. We're now trying to match that up. We're down to $215 million in an outstanding balances. And what we've learned is in the 2,600 providers at issue, it applies differently. So we're down to $215 million in dispute. This emergency legislation is necessary because our mental health care providers must have confidence in the process and the amounts they are owed. There must be a mechanism for reasonably determining this balance of $215 million. And I could go on and on and on, but the buzzer is about to go off. So
it went off.
We'll continue as needed. Can I just say one more thing?
Sure.
The situation we're faced with, as you know, is really the fault of the department and Optum. Okay, the providers had nothing to do with the situation they find themselves in. And Optum chose not to replace Encato, which was their subcontractor. And the department chose not to forego exacting punitive damages and penalties. So this is a poor and bad business arrangement between Optum and between the department. They both had options here. So it's our rule to not leave the session without creating an affirmative process for the providers, because Optum and the department have proven to be dysfunctional, and their promises to us throughout the interim that this situation was on its way to being fixed have not come to fruition.
Delegates, Valentino Smith, can you please wrap up?
Yes, I will finish with this. Optum on its website. Okay, just let's finish with this. This is what Optum says it is. Optum is part of a huge corporate conglomerate, and its website states that it's the fastest growing part of the United Healthcare Group, and it's global, leading information and technology enabled health services business, which serves virtually every dimension of the healthcare system, working with a diverse set of clients across 150 countries to deliver health services through innovative partnerships and provide technology and tools that enable unprecedented efficiency to develop strategies for better care at lower costs. This is what they advertise themselves of, and the testimony that you'll hear the reality.
Thank you. Thank you very much. Next, we have Ms. Lori Doyle. Ms. Doyle?
Thank you, Madam Chair.
You have
Lori
2
Doyle.
minutes. Thank you.
Thank you. Lori Doyle on behalf of the Community Behavioral Health Association of Maryland. This committee knows that we were hit with Optum at the same time we were hit with COVID in early 2020. The department had to provide advance payments or estimated payments because Optum's system failed to pay claims. Of course, we all remember that horrible time of 2020. People were dying and people were scared. The General Assembly even broke early that year. The department urged us to keep serving people, and we did the best we could. So now 2 years later, we're trying to figure out what is it we owe back, and that is not a simple process. First off, because of the impact of COVID, there was a downturn in services, particularly in certain lines like residential, where the quarantines hit and they couldn't pivot to telehealth. But the biggest complicating factor is Optum's dysfunction. Providers have been given amounts that they are told that they owe, but a recent survey of our 95 member organizations indicates that 2/3 to 3/4 of that amount would be offset by the claims from the estimated payment period that Optum has erroneously denied or otherwise not paid or credited against the repayment amount. That greatly inflates the amount providers have been told they owe. We're talking hundreds of thousands of dollars. We need transparency in this process, and that's what this bill requires, is that they either meet the standards or they hire at their expense an independent auditor that can sort through all of this mess. I'll close by saying that behavioral health providers really took it on the chin with the double whammy of COVID and Optum, and we're now facing making payments to the state at a time where we're being hit with unprecedented demand for services. We ask that you help maintain our behavioral health safety net by giving this bill a favorable report. Thank you.
Thank you so much, Lori. I appreciate your work. Next, we have Mr. Dan Martin.
Thank you, Madam Chair, members of the committee. Dan Martin with the Mental Health Association of Maryland, here in support of House Bill 715, You've heard how this situation is impacting behavioral health providers, but I want to take a step back and look at what it means for Marylanders broadly, because it's not just providers. This frustration about this Optum situation is felt far and wide. And I am speaking today not only on behalf of the Mental Health Association, which is a consumer education and advocacy organization, but also the Maryland Behavioral Health Coalition, which penned a letter to Governor Hogan in September, highlighting the challenges that you've been hearing about today and throughout the interim, and pleading for some kind of action to resolve the issue. And that coalition letter, which is attached to your written testimony, was signed by over 120 organizations from around the state. And it included providers, of course, but it also included consumer organizations, family organizations, peer-led groups, professional associations, hospitals, health systems, and more. And though not a single one of the system failures outlined in that letter has been completely resolved, providers now face the prospect of paying back large, unverified sums of money despite lacking reliable data to ensure Optum's math is correct. And so here is the gist. We are experiencing increasing demand for mental health and substance use services coming out of this pandemic like we've never seen before. We need our community providers' focus placed squarely on serving the public, but it's hard to focus on expanding service delivery when you have this administrative nightmare hanging over your head day in and day out. And I recognize that everybody is and has been working really hard to fix this situation. Providers, of course, Optum, the Department of Health, but we have to place consequences where they are deserved, and that is with Optum. It's their dysfunction that's causing these problems, and they should be the ones on the financial hook. Providers and the consumers they're serving must be held harmless as these reconciliation plans move forward. And for those reasons, we urge a favorable report on House Bill 715.
Thank you so much, Dan, and for everything you do. Next, we have Ms. Carrie Shaw. Ms. Shaw from Cornerstone, Montgomery.
Yes, thank you, Madam Chair and members of the committee. Carrie Guthrie Cho, President and CEO of Cornerstone Montgomery, the largest provider in Montgomery County. Let me start by saying that Cornerstone Montgomery is not opposed to paying back money that was erroneously paid. However, we cannot in good conscience and with fiscal responsibility pay something that we have been unable to verify without accurate and reliable supporting documentation. Optum is intent on steamrolling forward with recoupment, with inaccurate claims data, and irresponsible pattern of repeated errors and misstatements. Errors and misstatements that continue today. In December 2021, Optum denied 76% of our residential crisis psychiatrist services for no authorizations, all of which we believe to be erroneous because there is no authorization required for those services. You will find many examples of other denials in my written testimony, almost all of which we believe are incorrect. Those denials involve hundreds of claims and thousands of dollars to research and follow up on. We estimate our cost in staff time to address these errors to be close to $200,000 so far, based on the countless hours spent managing this fiasco. This entire situation has crippled our ability to manage and project cash flow with any confidence. It also means our FY21 audit will receive another qualified opinion because of this issue, and that could affect our ability to apply for grants. We simply do not have the cash reserves to just pay back potentially over $1 million on the say-so of a system that has been ineffective since its inception. House Bill 715 is aimed at giving providers like us the accuracy and transparency we need to ensure that what we owe is accurate and reasonable so we can continue to provide services to some of the most vulnerable in our community. We respectfully urge you to give HB 715 a favorable report. Thank you.
Thank you for being with us today. We have next Ms. Blumberg.
Yes.
Good afternoon.
Good afternoon. I don't know where my picture is. I'm so sorry. I have video.
We can see you.
Okay. Oh, okay. Thank you, Madam Chair. And
my pleasure.
The committee. I'm Sue Ann Blumberg from Upper Bay Counseling and Support Services in support of House Bill 715. We serve both Cecil County and Hartford County with an array of services. You are all well versed at the shortcomings of our ASO. I would like to share with you how Upper Bay Counseling has negatively been affected in the following 3 ways. Our cash flow, as has been discussed, We are unable, we have no idea how much Optum will ultimately, or the department, say that we owe back. We also cannot predict from week to week how much cash we are going to be receiving for the services that we provided the prior week. For example, last month, I just picked 2 weeks. One, we received 53% of our reimbursement for services. The next week, it was 156%. Another week, it was 5%. Another week, it was 300 and some percent, which makes it impossible for us with this fluctuation and really unpredictability to be able to expand, to serve properly, and it is destroying our financial stability. The second point is the cost and staff time. As Carrie has said, it's cost us, we estimate about $206,000, and that is a conservative estimate for our dedicated staff and for our billing manager just to try and figure out the past. It has nothing to do with current. And thirdly, our level of frustration and disappointment. Our staff find it very difficult to find solutions. Optum support is missing or incorrect. And with the Department of Health, who has not really helped to resolve this or hold Optum accountable for this poor system. We did not cause these problems or hire Optum, who gave Maryland an ill-equipped system to meet the needs of providers. So therefore, I am asking for a favorable report for House Bill 715.
Thank you so much for your testimony today. Next, we have Chandra Chester.
Good afternoon, Madam Chair and committee members. Thank you for the opportunity to speak here today. I'm Chandra Chester, Vice President and co-founder of Families First Counseling and Psychiatry. We are in Baltimore City, Howard County, PG County, and Montgomery County. We employ 103 individuals and serve approximately 1,800 clients a year who mostly have Medicaid. Over the past 2 years, Families First has endured 2 crises. Since Optum took over as the ASO, it has been a nightmare for Families First Counseling and Psychiatry. We experience a higher rate of claim denials from Optum than we have with any other payer. In addition, the pandemic disrupted our services, causing our normal referral sources from schools and pediatricians to dry up. The impact of both of these disruptions significantly reduced our revenue. Because of Optum, Families First was also forced to hire additional billing staff, pay overtime, and overwork our staff, resulting in increased costs. Due to the increased costs and decreased revenue, we have had to restructure and cut positions. We have clients with significant mental health needs ranging from trauma to psychosis on a wait list due to having to downsize and not having enough therapists to serve them. Referring them out isn't an option in most cases because many clinics across Maryland are dealing with the same crises. This is a huge disservice to the population we serve during such a critical time when there has been a significant increase in children seen in the emergency room for suicide attempts. On top of it all, Optum is seeking to recoup $313,000 from Families First when we have $471,000 in submitted claims that have been lost or denied due to Optum. The volume of unpaid claims substantially inflates the actual amount Family First owes back to the state. Recoupment will further reduce Family First's ability to provide treatment to children and families in your district. I ask you to support House Bill 715 and debt relief for behavioral health providers so we can focus our attention on meeting the needs of your constituents. Thank you for your time.
Thank you so much for being with us today and for the work you do. So members, this ends the favorable panel. So we're going to ask questions and then we have an unfavorable panel. So I am opening it up for questions now. Are there any? I have first Delegate Bagnall, followed by Delegate Robin Lewis.
Thank you, Madam Chair, and thank you to the bill sponsor. You know, this is an issue we all have been struggling with. You did mention that this was an emergency bill. Is this filed as an emergency bill, and or are you planning to amend it to be an emergency bill?
I drafted it as an emergency bill, but you know, we all got to go back and read our bills when we get them back. Hold on. Yes, it's drafted as an emergency bill.
Thank you. Thank you, Madam Chair.
My pleasure. Next, we have Delegate Robin Lewis, followed by Delegate Landis.
Thank you, Madam Chair. Thank you to the bill sponsor, Delegate Valentino Smith. We've been listening to these alarming reports from behavioral health providers around the state for months. And I think it's unacceptable that the problems persist. My question for the bill sponsor, who knows a thing or two about how the health care system is run and funded, why do we pay third-party vendor to cover the costs of behavioral health care? Why do we do this? We outsource this important, essential function of the state to a private company that does not perform. I just have failed to see any benefit, and I'd like to know, in your view, why we should continue to do so. Thank you.
Thank you, Delegate Lewis. And that's certainly giving me a lot of credit. I don't know that I deserve it, but I do believe that based on the years and years and years, as most of you know, I used to represent hospitals and physicians before I became a delegate, and have been in the good HGO committee for so long, that we switched to ASOs and we've switched around the delivery of healthcare, I believe, for the unfortunate goal of saving money. And in a goal to spend less money, we've jeopardized quality. We've jeopardized quality in a lot of different areas, not just here. Now, when they switched to the ASO, it was to save money, but the prior ASO, which was Beacon, and the providers can speak more to this, actually was chugging along fairly well. And then we put an RFP out, and I was shocked in the behavioral mental health budget that I got just a couple of days ago. This is what we were told, that Optum's bid was scored as the best price, and it was $72 million cheaper than Beacon's bid, and estimated at $10 million less a year. So when I read this in the budget report, Delegate Lewis, it tells me that the contract was awarded for the pure purpose of saving money with disregard for the functionality of it, and that the department has been overly patient with Optum because they've given them so much startup time to get their processes correct that in the bid, one would believe they had made attestations that they had a process that could manage this. So I think it is unfortunate just to save some money and jeopardize.
Thank you. Thank you for your answer. If I may, Madam Chair, I know we have 1,000 witnesses, but is there any reason to continue using these outsourced companies to provide a basic function of government when we're simply Beacon's performance not relevant in this conversation, when we're paying for a service we're not getting, our providers are under stress, and our people are not getting the care they need?
Well, I don't know that I can answer that. And I know we have a lot. I can tell you that the unfortunate concern that I have about also bringing it back in-house as sitting in the Appropriations Committee is we are severely understaffed and underfunded with what we pay state employees right now. And so our ability to actually attract and retain a significant workforce for what we are doing ourselves now is in severe jeopardy. In terms of why we continue with Optum, I think the contract's clear, and I'll get to your office the most recent JCR report that there are, they have withheld $1.3 million in damages through November 21st, and they only withheld 4% for them failing to meet 11 of the 12. Why they picked 4%? Seems like they could have withheld a lot more money. And they could have been exacting $25,000 a day in liquidated damages for failing to provide a working system. I haven't done the math for the number of days, but certainly a lot of this money could go towards the deficiency that they're concerned about in the budget for the $215 million that's at issue. And if I just may say, the $215 million deficiency is for one or two things. It's either for claims that were rendered services were rendered that we should be getting matching federal money for that we're not, because we can't figure this out. Or therefore estimated payments where services were not provided, and the providers have said they're willing to return that money or not continue, to claim that they're deserving of that money.
Okay, thank you. We have a lot of questions. The next one is Delegate Landis, followed by Delegate Lewis Young.
Thank you, Madam Chair. I'll be very quick. This question is for the sponsor. So is Optimum saying that it's provided a full claims history report to providers? And if so, will this address their concerns?
Oh, thank you, Delegate Landis. In the essence of time, Madam Chair, if you don't mind, I think I'll let Ms. Doyle answer that question specifically from.
Sounds good. Thank you. Ms. Doyle.
Thank you for the question, Delegate. And it's a timely one. Actually, there was a meeting of Optum, the department, and providers yesterday to talk about the full claims history report. What we know is they just came out 2 weeks ago. Not everyone has one yet, and they are voluminous. We've been asking for these for almost 2 years now. One provider on the call yesterday stated that his spreadsheet was, listen to this, the spreadsheet was 1 million rows long and 20 columns wide. That is a lot of data to get through. Now, not all are that big, but they are extensive, and it's going to take a lot of time to get through them. And the only other thing I'll say is that the reports yesterday were that unfortunately there are still substantial errors in that report, but we won't know how extensive they are until we can sift through it a little more.
Thank you.
It was very disappointing, Delegate Landis, that this magic.
Delegate Valentino Smith, we're only allow one person to answer the question.
I apologize.
Okay, thank you. We have, unless Delegate Landis would like a follow-up.
Oh, I'm allowed? Okay, thank you.
Yes,
I do have
sure.
one more question. So, because I don't normally.
I know, that's the reason why.
I know, thank you. So I'm very curious about this. Have providers received their recoupment amounts? And if so, what impact will paying those amounts have on providers? And I don't know who's best to, I guess.
Who's the best person to answer that, Delegate Valentino Smith?
I'm going to let Ms. Doyle take that. Thank you.
Thank you.
Thank you, Delegate. So first off, what we know is that the amounts are not accurate because of all the claims submitted during the estimated payment period that were erroneously denied or left unpaid. So the amounts are inflated to begin with. But we know that the payments back, regardless of where they are going to be stressful for providers. We know that they will exhaust much, if not all, of their cash reserves. Some will have to take out lines of credit. Others will be cutting back service lines and implementing staff layoffs. And unfortunately, we're already starting to see those things happening now.
Thank you.
Thank
you, Madam Chair.
My pleasure, Delegate Landis. We have next Delegate Lewis Young, followed by Delegate Riley.
Thank you, Madam Chair. I'll pose this question to anyone that wants to answer. It's a variation of Delegate Lewis's question. Since clearly Optum has violated the terms of the contract and therefore making the contract null and void, I don't understand why another RFP wasn't issued. And assuming that the department cannot handle this function internally and they need to outsource it, after the 10th major calamity, why didn't they search elsewhere for a replacement? The contract was clearly not binding at a certain point.
Who's the best person to answer that?
I will try again, if I may.
Thank you.
So I think from the department's perspective, it would have been disruptive to reissue an RFP. We, from the provider side, have been saying at the very least, have Optum replace their sub-vendor in Cato that is in charge of processing claims and doing all these things that they have not been able to do. We've had, this is our 4th ASO. They have all been very successful in doing what they do. This is the first time we've hit this kind of a challenge. So it's time to look at a fix. So thank you for your question.
Thank you.
Thank you so much. We have Delegate Riley, followed by Delegate Kerr.
Thank you, Madam Chair. Yes,
My
my
pleasure.
question basically was in reference to the claims history report, the itemized report. So you kind of already answered that, but I will go to Delegate Valentino Smith to let her follow up on what she was going to say since I was called on. Thank you.
Thank you. I think really it had to do with the amount of deficiency and the claims reporting that's out is why the bill is necessary as an emergency bill, but that when I send you the budget reports, you'll see where the budget analyst is proposing where there may or may not be some room for money to be available to do some more forgiveness for some of the providers.
Thank you.
Thank you.
All right, thank you. Delegate Kerr.
Thank you, Madam Chair. Delegate Valentino Smith, are there provisions in this bill that ensure that any financial penalties that are paid won't simply be passed on to consumers?
No.
Thank you. Thank you, Madam Chair.
My pleasure. Any further questions for Delegate Valentino Smith and her panel? Seeing none, we're going to call the unfavorable panel. Thank you, Delegate Valentino Smith. We have first Mr. Joseph Nguyen.
Can you hear me?
Yes. Good afternoon.
Madam Chair, members of the committee, good afternoon. My name is Joe Nguyen, Vice President of External Affairs at United Health Group. I'm here in opposition to House Bill 715. 715 would make it more difficult to recover overpayments from providers whose services, who delivered, 715 would make it more difficult to recover overpayments from providers for services that were not delivered during the first half of 2020. This process is known as reconciliation. It's been referred to several times by the previous panel. To date, several hundred providers from large practices to smaller groups have fully reconciled, and more than 800 million has been recovered thus far. This bill does not reflect the current state of the ASO, which is paying around 34 million on average a week to providers in the behavioral health program. Additionally, claims history reports that were mentioned have been delivered. Of the 683 providers that have requested those claims history reports, they've all received them. As of this Monday, this week, 187 of those claims reports have been opened by providers. These transaction files known as 835s are also being delivered in standard formats as well. I'm joined today by Optum's Chief Operating Officer, Chad Burkholder, for additional background. And if it's okay with the chair, I'd like to yield the remaining time to Mr. Burkholder.
That sounds fine. Good afternoon.
Good afternoon. We appreciate the time, and we absolutely understand the importance and the urgency of this topic, and would publicly thank the providers for their ongoing engagement. As we have said before, we certainly admit that this process has not gone as we wish, although, as Joe just mentioned, the way that things are being conveyed in the bill, as well as frankly in the discussion today, are not reflective of current state. They are reflective of a time in the past, and we have acknowledged that publicly in the past, and have worked hard to rectify that. As Joe's mentioned, one of the primary elements that's being discussed here today is a supposed significant gap in even current payments. And as Joe mentioned, we're paying between $34 to $40 million per week, which at this time is now in excess of what was regularly experienced with the prior ASO. In addition, there's been a lot of assertions about erroneous denials, although again, the denial performance of the current structure is in line with what was experienced by the prior ASO. Inventories, as has been referenced, have been managed very, very well, and we do not have any current inventory in excess. And that includes any backlog of denials that need to be adjusted by Optum. Optum did take active steps to address systematic challenges that drove erroneous defects. Much of that work was completed in the fourth quarter and the very beginning of January as well. At this time, there is roughly $81 million worth of denied claims that fit in buckets that look like erroneous submissions due to a provider type or data service, et cetera. And so those things need to be addressed. And then finally, from a reconciliation perspective, we're really focused at this time on engagement. We're seeing the engagement that Mr. Nguyen just mentioned, and we have just released the reports that were mentioned. Of 683 reports that have been delivered, only 187 of them have been actioned upon, which indicates that frankly the providers need to engage more explicitly. So at this time, I appreciate. I see the clock is up. I appreciate the time to speak with you today.
Thank you very much for your testimony today. And now we're opening it up for questions. So I have first Delegate Krebs.
Thank you. And this is a
pleasure.
question for Optum. We had a bill hearing, I guess a month ago on the very same issue. And I'm not going to go through the all of the questions that we posed back then, and we still have the same issues in front of us. And we sent you over, the reconciliation process was an issue to a number of my providers because they had to sign off to accept money and say they didn't even know what they were getting. They didn't even know what they were getting paid for. And we sent over a bunch of examples from our providers asking for feedback. So what I'm trying to figure out is where are we today compared to where we were last month when we had a very robust discussion about all the deficiencies with all of our providers throughout the state. So how do we get you gave us big numbers, but that does not include the fact that our reconciliation process was not understood by the providers. So, and I've never heard back from you on any of the situations that I gave you. So how do we really understand, not just X amount of dollars, whether or not our providers have been paid and they understand the reconciliation process of what they've already been paid and don't understand what it's for? How do we understand that?
Sure. Thank you for the question, Delegate. So there's two elements. So one, to be very clear, and this actually came up earlier today as well, a question was asked, do providers know how much they owe in estimated payments? Or how much, I think the question was, how much will be recouped? They know what their current estimated payment balance is. The recoupment itself will be determined after reconciliation is complete. The element that you're mentioning is actually related to a situation referred to as negative balance, which is slightly different. It's not related to estimated payments. That's a situation, and significant portion was a result of systematic challenge in which funds were paid from one account, for example, Medicaid, instead of state account, and then in needing to reverse that created a negative balance because of providers being paid twice. There are other situations in which a provider can contribute to their own negative balance through an error. It's a normal occurrence. It's something that happens, and what you're referring to specifically is the direction of MDH to begin the collection of any of those particular elements that were negative balance in nature. That's separate, entirely separate from estimated payments. And the best way for us to address the estimated payments reconciliation is the use of the claims life cycle report, the use of the 835s, which are being released and continuing to be improved. And then equally, if not most importantly, is ongoing engagement with reconciliation manager to help answer any particular questions and assist with the resubmission of claims, if indeed that is what needs to be done. And at this time, largely, if a provider wants to minimize the impact, they largely will have to address administrative items that caused other denials to take place.
Well, I just want to make one statement that it's been very a dissatisfactory process for everyone. I've been here a long time. There's been more problems, as was said, with this than ever I could have imagined. And the last three providers, we did not have these problems. So it's been very disappointing. And I still haven't had the reconciliation that we asked for a month ago for the stuff that we sent over to you. But I would appreciate some feedback on that.
I will absolutely make a note of it and we'll follow up. And I apologize for any delay. We will look into that immediately, Delegate Krebs.
Thank you. Chairman Pendergrass.
Thank you, Madam Chairman. My first question is to the Secretary of Health. Are you here on this bill that is to some extent the fault of the contractor and to a larger extent the fault of the agency that has not clearly done any kind of a decent job on making sure that they are held accountable? So are you here, Mr. Health Secretary, so that you can answer for these shortcomings in the job that your department is doing or not doing? Again, absent. Thank you. Beyond that, I'm sorry to say to Optum that I wanted to believe that this was improving. I wanted to believe, how many times do you think we've had this as a subject of a hearing or a briefing? A dozen times, maybe in 2 years, more, maybe in 2 years. We get tired of hearing everything is going better, we're solving the problem. My trust has been lost. I'm sorry to say that to you, but either one of you, how do we get to trust you? How do we get you to work with the department to do the job that we've contracted with you to do?
Who will be best to answer that question?
Sure, I'll attempt to address it.
Please.
To the extent you've lost trust in me and my relationships with you and members of your committee, I apologize. We believe that regaining trust with the committee is through engagement. We're here to talk, and we will always be available to talk to any member of the committee at any time in great detail in any forum. So I'll let Chad answer for his part.
Yeah. Well, and again, I understand the urgency of the feedback. Frankly, we feel similarly frustrated. This isn't how we run our business, and we're frustrated with this situation. Frankly, I think there are many, many contributors to it. And today's not the day to go into great detail of that. But I think to the point of, are things being improved? I think Joe summarized it. At this point, engagement is the only path forward. And if we can get past reconciliation, we have high confidence that things will feel much more stable for our provider partners. We see that as the major step that needs to be taken. And only after that will we be able to demonstrate more stability. Because at this time, we're really commingling a lot of issues, and I understand why. And frankly, we take accountability for why that has happened. But I think that's the path forward, Chairman Pendergrass, and we're committed to getting through that process with urgency.
Madam Chair, may I have a follow-up?
Yes.
Thank you. I think of engagement to a great extent on the part of the legislature as having briefings and hearings. It seems to me we have been engaged. That hasn't solved the problem. I must get a constituent letter on this on a daily basis in my district. And I expect that I'm not the exception. This is really a mess, and I hold the department greatly responsible for the mess because they're supposed to be dealing with a contract. But again, what is engagement if not this?
Yeah, and to clarify, what I really mean is our ongoing engagement with the providers to work through the reconciliation process itself and to complete that work. We're now
what
greater.
What follow-up are you doing to make sure that the providers have received all these things that you've sent to them when about 400 of the 600 haven't replied or haven't opened the document? What are you doing to engage with the people who are having such a hard time working with you?
We are engaging directly through phone call. We're engaging through numerous meetings per week in group settings, and we are responding to any inquiries they make within our provider relations group, et cetera. So with various ways, meetings, telephone calls, emails, and all those methodologies to attempt to engage.
Thank you, Madam Chair.
My pleasure. Next, we have Delegate Kipke, followed by Delegate Bagnall. Delegate Kipke.
Thank you, Madam Chair. I'm a constituent of mine who's a licensed clinical social worker who deals with Medicaid individuals largely, recently told me that she's just done. She can't deal with this anymore. And, that made me sick to hear that. I wonder how many other providers have just bailed on this whole thing. But so I just throw that out there because I felt like I needed to, not to pile on. And I do appreciate you, Joe, always responding and being really responsive with me. My question though is, and I apologize if you already explained your position on this because I'm multitasking, but people complained about this contractor that you all use. Can you expand on, or, have you looked at other options with this contractor that there seems to be a lot of blame being directed towards? Can you just provide some insight on that? Thank you.
Sure. Thank you. Thank you, Delegate Kipke. So we are actively evaluating, have actively evaluated systematic changes within the Encato tool itself, and we have also examined, other means of alternative in order to be able to support the providers, and that's an ongoing matter of discussion with the department and with providers. And so, at this point, I don't have any additional comment that I think I could offer other than to say that we will always be open to engaging with the department and providers related to how we can improve this tool or any other tool in the future.
Thank you. Delegate Lewis Young. I'm sorry, Delegate Bagnall, followed by Delegate Lewis Young.
Thank you, Madam Chair. I'm okay with piling on a little bit because we've been working on this issue for a long time. We had emergency legislation last year as well. And I had a constituent who shared with me last week that they had to take out a $60,000 loan to make payroll. So my question to you is, are you factoring in this process the additional administrative costs? Who is paying for arbitration, and who is then the final word on what is owed and to whom without this legislation?
Thank you for the question, Delegate. I think that question is more appropriate for the department themselves. And I'm not sure that we would be in a good position to offer, opinion or commentary on those elements.
Madam Chair, could I have a follow-up?
Yes.
Well, since the department isn't here, can you consult with the department and get us an answer?
We will absolutely take it back. Absolutely, Delegate.
Thank you very much. Thank you, Madam Chair.
My pleasure. We have next Delegate Lewis Young, followed by Delegate Johnson, and then Delegate Hill.
Thank you, Madam Chair. Perhaps I didn't hear this correctly, but my question is, why is the administrative burden of proof on the provider? I'm not sure why you don't automatically send out reports to all the providers without them having to ask for it. Isn't that standard operating procedure? As recently as a month ago, I had a constituent who'd been trying to engage for over 6 months and finally came to me out of desperation to try to get payment. So I would think your organization would be more proactive in communicating and not put the burden on the provider, which further complicates the problem.
So I think there's a couple elements to your question. So one, we are sending, reports on a regular basis. The 835s are being released on a constant basis. And now what I would acknowledge is that there was a data challenge that was impacting around 0.75% of some of the claims lines associated, and that is being corrected and will be, we were expecting, roughly 99.97% data integrity as we go forward. So that is absolutely an important improvement that needed to be addressed, even if it is less than a 1% error. However, the other element there in your question in terms of administrative burden, what we're doing through the reconciliation process is we're sharing the information relative to what has been submitted, what has been paid, what has been denied. The only administrative burden is to have providers have to correct specific submission errors that took place in order for a claim to be reconsidered. Any claim that was the result of Optum's execution or our systematic execution issues have already been addressed, and were addressed in the fourth quarter as well as early in January. So the administrative burden really is around a claim that may have been submitted incorrectly and needs to be resubmitted by a provider, or a denial may frankly simply be the result of what has been an evolving state policy. Policies associated with the ASO today are materially different than they were under Beacon. That's was one of our charges, was to administer those policy changes. Those items, no question, are also aggravating to providers. I hope I'm addressing your question.
You did address the question, but there's a very different perception from the providers.
I understand that, absolutely. And frankly, we are frustrated by that as well, and really seek to address that, because it is an impact on both organizations, and we're very sensitive to that. Or all organizations, I should say, provider organizations and Optum and MDH.
Thank you.
Thank you.
Delegate Johnson, followed by Delegate Hill.
Thank you, Madam Chair, and
My
thank
pleasure.
you for coming today, witnesses. Following up on Delegate Lewis Young's last comment about a very different perception from the providers. You're here again today telling us everything is going great. You're getting the reports out. Everybody's getting things done. But was not Optum at a CBH meeting just today where the providers made multiple complaints about the report you sent out, about missing data, incorrect data, and you keep talking about the 835s. You've given them until the end of April to unravel this mess. And those 835s have thousands of lines of data that they have to sift through. So can you tell us a little bit about today's meeting?
So I do not have direct insight into today's meeting, Delegate Johnson, but I'm glad to follow up on it and identify, what were the topics of discussion. As for the timing and any requirements, again, I think that's actually more a question for the department. Optum is not determining any timeframes associated with requirements, and I wouldn't be in a position to speculate about those requirements or any flexibilities.
So you don't know about any complaints of missing data or incorrect data with the report?
The overwhelming feedback we have received on those reports has been incredibly positive. Whatever feedback was offered in a meeting today, I have not received as of yet, but believe me, I will be following up immediately following this. But like I said, the overwhelming feedback that we have received has been very much positive.
Thank you, Madam Chairman.
My pleasure. Delegate Hill.
Thank you very much, Madam Chair.
You're welcome.
Thank you, Mr. Bowcroft, for engaging with us today. Would you all provide to this committee the number of distinct MPI billers? And by we don't need the MPI numbers, but I want to know the number of providers that were submitting bills to you, baseline the month that you started as the ASO, the number that were submitting bills to you a year later, and the number that were submitting bills to you, I don't know, January or February of this year, whatever is most recent, so we can actually look at, to Delegate Kippy's point, if we're seeing a number of providers who've just walked away.
I make a note of that, Delegate Hill, and absolutely we'll take it back, and we can work with our team as well as the department to understand, the data availability, and then work with your office to share any important insights.
Thank you. We don't need it de-identified. As I hope you understand that, right? We just need to know the total numbers. Thank you. And consistent methodology for each of those 3 reporting periods. Thank you.
Are there any other questions for this panel? Seeing none, this concludes the bill hearing on, one second, apologize for that, on House Bill 715. Thank you for being with us today. Next, we have House Bill 906, Delegate Lewis, Health Equity Resource Community Modifications. I think that there was a note that stated that Delegate Lewis may not make it and there was going to be someone from his office. Is that person here?
Oh, I'm so sorry. I thought you were talking about me. I almost had a fit. I'm sorry,
No.
Madam Chair.
No, it's okay. Delegate Jas Lewis. Is he here today? Is there someone that is going to testify on House Bill 906? Okay, I don't see him.
They are here. They just haven't unmuted.
Okay. From Delegate Jas Lewis, will you be so kind and please unmute yourself? Are you able to unmute the person, Susana?
No, I can only request for them to unmute.
From Delegate Jas Lewis, are you here? Will you be so kind and unmute yourself? We can see you, but you're muted. Mr. Henry Snore? Yes. Mr. Henry Snore, I see that you're here for Delegate Lewis, Jas Lewis. Well, why don't we just go to the panel while maybe the person stepped away? Why don't we start with the panel? Okay. So we're going to start with a favorable panel, and we're going to start with Catherine Rogers. And Catherine Rogers, you have 2 minutes, and you're testifying on House Bill 906, which is Health Equity Resource Community Modifications.
Hi, thanks for having me. I'm Kat Rogers. I'm Director of Community Health Initiatives at Tidal Health, and I'm here to provide an overview of Tidal Health's project, the Rural Equity and Access to Community Health, or REACH, which employs innovative and evidence-based cross-sector multi-level strategies to address the 5 primary goals of the Health Equity Resource Act. Our project's going to reduce and prevent diabetes and hypertension, specifically among our Black and Haitian adults on the Lower Eastern Shore. There are significant racial health disparities for these conditions throughout our region. The data also shows a strong correlation between social determinant of health factors such as poverty, transportation, language, internet access, and poor health outcomes. Key to the success will be implementation of interventions at the individual, community, and system levels in partnership with our federally qualified health center, 2 local health systems, our local health departments, and our health-focused grassroots nonprofits. At the individual level, we'll expand our mobile integrated health program, which optimizes a nurse-led multidisciplinary care coordination team that conducts social and health assessments post-discharge for our patients, remote patient monitoring, as well as links to bilingual community health workers. At the community level, we'll work with our nonprofit partners to expand access to evidence-based chronic disease self-management and prevention programming in the prioritized communities and zip codes and in multiple languages, as well as expand access to mobile health screenings in at-risk neighborhoods. At the system level, we'll increase access to linguistically and culturally sensitive care, and we're working to standardize social determinant of health screenings and referral processes across all sectors. Under this grant, we will collaborate strategically with our stakeholders and partners to advance health equity throughout the area of the Lower Eastern Shore and meet the needs of our historically disadvantaged communities, while also building infrastructure for sustainability. Thank you.
Wonderful. Mr. Henry Snur, we were calling you. Are you here on behalf of Delegate Lewis?
Yes, Chair. So sorry.
Okay, it's okay. It happens. Don't worry. You have great witnesses. You have 5 minutes to present.
All right. Thank you, Madam Chair and members of the committee. I'm here to testify in strong support of HB 906 on behalf of Delegate Jas Lewis. This bill alters provisions relating to health equity resource communities. First, it requires Chesapeake Regional Information System for our patients, otherwise known as CRISP, to provide technical assistance to Maryland Community Health Resources Commissions, MCHRC, in executing HERCs. Second, HB 906 will delay the date that MCHRC must issue a request for proposals, otherwise known as RFP, to designate HRCs from October 1st, 2022 to October 1st, 2023. The purpose of this is to ensure that the state has time to thoroughly review the data coming back from the first round of grantees before making any further awards. Finally, it will also expand the purpose of the HERC Community Reserve Fund to include funding of 2 full-time staff positions in 2022 in covering the cost of CRISP, providing technical assistance to MCHRC through the fiscal years 2024 and 2025. Last year, the General Assembly led a bipartisan effort to address health disparities here in Maryland. The Maryland Health Equity Resource Act provide new resources to address health inequities, improve health outcomes, and reduce hospital costs across Maryland. When this act became law, the commission has since worked with the new HERC Advisory Committee to develop the first RFP, the Pathways to Health Equity call for proposals. Under Pathways, the commission was able to grant 9 awards across Maryland, specifically 3 in Prince George's County, 3 in Baltimore City, and 3 across rural Maryland. This represents a wide diversity, and it's reflected in these grant recipients. And it shows the ability of this program to address the wide variety of health disparities that exist across Maryland. The modest adjustments in this bill has no fiscal impact and would give the CHRC more time to evaluate the proposals they receive and help the implementation of this vital new program. HB 906 will allow Maryland to continue its fight to reduce both physical and mental health disparities across the state. And for these reasons, I urge the committee to provide a favorable report. Thank you so much.
My pleasure. And I know you have in your panel, Mr. Mark Luckner, that actually you can have the rest of the time as well, okay?
It's great to see you again, Madam Vice Chair. It's great to be before the Health and Government Operations Committee.
Thank you.
You have our written testimony, so I'll be very brief. As everyone that spoke before me mentioned, this improves upon the bill, the fabulous bill that your committee approved last year. And as Henry said, our commission made 9 awards totaling $13.5 million. And as Henry said, 3 awards will support projects in Prince George's, 3 in Baltimore City, and 3 in rural areas. And you just heard from Kat, our new grantee from Tidal Health. And thank you for being part of the panel, Kat. Of those 9 awards, I remember last year the committee was very interested in the prior Health Enterprise Zone initiative that our commission was involved in, as well as the Department of Health was. So of the 9 awards we made, 5 support the prior Health Enterprise Zone initiative. So we heard legislative intent, and the awards before you reflect that legislative intent. This bill before you, and thank you for Delegate Lewis for sponsoring the bill. And I would also thank your council for also working with us on producing last year's bill. It makes a couple of minor, modest adjustments to help us as we continue to implement this 5-year program. The most important of which is, number 1, to push back the next RFP that we'll issue from this coming October to October 2023. It'll allow the 9 grantees, one of which you just heard from, more time to implement their programs, because we remember the awards we just made is called, and thanks to your council for coming up with this term, the Pathways to Health Equity Program. So these are 2-year pilot grants that will lead to a larger health equity resource community RFP that we'll issue under this bill in October of 2023. Second, we'll enter into a second contract with CRISP to help us evaluate the future HERC awards. And then third, we will use the new HERC fund produced under the bill that starts $15 million in his fiscal 23. That's the budget that you have before you this year, to cover the staffing costs of the 3 new additional PINs that we will hire to help implement this program. The first of which is the HERC project director. And I'm thrilled that we got 40 resumes of qualified individuals. And I'll be very excited to be back before you with the new HERC project director at my side, who will be helping me implement this program, as will the other staff members of the Human Health Resource Commission. So with that, I would be happy to answer any questions. And thank you again for hearing this bill today.
And thank you for your work and commitment to reduce health disparities. The committee appreciates it. Next, we have Jen Taylor.
Oh, Jen Thayer, she works with me at the commission. So
Okay.
In fact, Jen, why don't you say hello to everybody? I think you may know many of them. So I'm in very good hands in Jen Thayer's office. Yep.
Good afternoon. Members of the
Good
House of Government. Ditto.
Me too.
Thank you. Thanks
Me
for
too.
your work. We appreciate it. Next, we have Ms. Catalina Sol.
Hello, how are you?
I'm doing well. Thank you for being with us.
Thank you. Good afternoon, Chairman Pendergrass, Vice Chair Peña-Melnick, committee members and staff. My name is Catalina Sol, and I'm the Executive Director of La Clínica del Pueblo. Thank you for the opportunity to testify before you in support of HB 906 and to share information about La Clínica and our Pathways to Health Equity Initiative. La Clínica is a federally qualified health center providing comprehensive health and community services to primarily Latino immigrants in the Washington metropolitan region. We were founded in 1983 in response to the waves of Central American refugees arriving to the district in the 1980s. And as our community has grown and moved into Prince George's County, we too have established services in Maryland. Today, we operate a clinical site in Hyattsville. We provide mental health services to unaccompanied minors at Northwestern High School, and we provide a range of community health education and linkage to care activities throughout the county. La Clínica has always operated under the conviction that health is a human right and that health is produced not only within the four walls of a clinic, but in the environments in which we live, work, and play. We also understand that it is not possible to achieve high-quality health outcomes without addressing the inequities in health access related to race, class, and immigration status. Over 60% of our patients in Maryland are uninsured and ineligible for health insurance and have been heavily affected as essential workers during the COVID pandemic. For this reason, we feel very fortunate to partner with the Maryland Community Health Resource Commission in the Pathways to Health Equity program, where we will focus on addressing the disproportionate rate of diabetes among the Latino community. Our project will provide culturally and linguistically appropriate care coordination and integration with hospital and specialty care, partnership with key local partners to address food insecurity and immigration legal services, and community awareness and education campaigns. We expect to reach 6,300 community members with our public campaigns, demonstrate improvement in diabetes outcomes for 180 individuals, and engage our coalition of partners to further address the health equity needs of our community. Thank you again so much for the opportunity.
Thank you for being with us and for the work you do. Are there any questions from the committee on House Bill 906? Seeing none, thank you so much for being with us today. This concludes the bill hearing on House Bill 906. Next, we have House Bill 746, Delegate Kaiser, Maryland Medical Assistance Program, Gender Affirming Treatment, Trans Health Equity Act of 2022. Good afternoon, Delegate Kaiser.
Good afternoon, Madam Vice Chair. Good afternoon to everyone on the committee. It's my pleasure to join you today and offer testimony in favor of House Bill 746, the Maryland Medical Assistance Programs, Gender Affirming Treatment, otherwise known as the Trans Health Equity Act of 2022. This bill will modernize coverage for dealing with gender dysphoria. Ultimately, what this bill is about having Maryland Medicaid covering an array of gender affirming treatment in a non-discriminatory way. I really want to point out, as I say in my testimony, but some language in the fiscal note. We're talking about medically necessary treatment consistent with current clinical standards of care by a licensed provider for the treatment of a condition related to the individual's gender identity. Key to this definition is medically necessary, and also key is prescribed by a licensed healthcare provider. This bill is a result of consultation with the Maryland Department of Health and well as many medical professionals. Based on old standards, Maryland denies coverage for 31 gender affirming procedures, such as hair, voice, and facial procedures. And by including these procedures, we can improve the standard of care for transgender Marylanders, as some of our neighboring states have already done. I think this bill is a simple case of providing equity. We're talking about a small population of people needing certain services, which should not increase the bottom line, but most importantly, it's about improving the humanity in our state and ensuring that everyone gets proper healthcare coverage. I urge the passage of House Bill 746 and leave the balance of my time to, I believe Sam Williamson is going next.
Okay, so who would you like to call first?
Sam Williamson.
Okay, wonderful. Mr. Williamson, will you be so kind?
Thank you, Chair, Vice Chair, and members of the committee. It's totally fine for the opportunity to share my support for HB 746. I also want to thank our sponsors in the room, Delegates Kaiser, Carr, and Lewis Young. My name is Sam Williamson. My pronouns are they, them, and I'm a lawyer with the Homeless Persons Representation Project. We have offices in Prince George's and Montgomery counties and in Baltimore City. Today, I'm going to share a little about the history of this bill, explain what the bill does, and then I'll talk about the very small fiscal impact. In 2016, the Maryland Department of Health created a policy on Medicaid coverage of gender-affirming care. The policy is based on medical standards that are now over 20 years old, and they are very far out of date. The policy categorically excludes 31 specific procedures, which means that no one can get coverage for those procedures, even when they're medically necessary and even when they're prescribed by a doctor. Multiple courts have found that these types of categorical exclusions violate federal law and violate non-discrimination provisions. And every major medical association has found that the care that Maryland currently excludes is medically necessary. As Delegate Kaiser mentioned, this bill is a result of a series of meetings with the Maryland Department of Health and with medical professionals from Johns Hopkins Medicine, Chase Brexton Healthcare, MedStar Health, and others. After talking with all of these medical experts, we have created a bill that would bring Maryland into compliance with medical and legal standards. The language of the bill is drawn from other states such as Virginia that already require gender-affirming coverage to be based on current medical standards, and for coverage to be individualized, meaning no categorical exclusions like the one seen in Maryland today. The bill would require Medicaid to cover gender-affirming treatment when it is medically necessary for the individual and prescribed by a licensed healthcare provider in accordance with today's non-discriminatory medical standards. The bill would also prevent Medicaid from denying necessary treatment because of an individual's gender identity, and it would prevent Medicaid from categorically excluding particular gender-affirming care procedures, meaning that care must be provided according to individual medical needs as assessed by today's standards. You'll also see an amendment to this bill. The amendment comes from the support of MedChi, who agrees that this care is necessary and identified a way to strengthen our bill. By removing the particular named procedures and leaving just general categories of care, will enable the bill to better keep pace as medical science advances. This bill will have a profound impact on Maryland, and it will only cost a very small amount. There are fewer than 2,000 transgender Marylanders who are enrolled in Medicaid, and only a small portion of this small group would use these services. For example, one study has shown that only 13% of transgender individuals need vocal surgery. And all of these procedures are eligible for federal reimbursement. What that means is that we would be spending approximately 0.1% of Maryland's Medicaid budget on this care. This is a very small drop in a very large bucket for a program that has a $100 million surplus. Maryland would also see cost savings because when we adequately cover gender-affirming care, the physical appearance of transgender people is more able to be congruent with the internal sense of self. This acts as a protective barrier. Transgender individuals are 30% more likely to face harassment and violence when other people can tell that they are transgender. And so providing this care is a barrier against discrimination in housing and employment. HB 746 makes fiscal, medical, and legal sense, and I urge you to issue a favorable report. Thank you.
Thank you, Sam, for your testimony today. We really appreciate it. Next, we have Elise Pine.
Good afternoon, Chair Pendergrass and members of the committee. My name is Elise Pine, and I'm a pediatric endocrinologist at Chase Brexton Healthcare, an FQHC that provides medical and mental health care for over 5,600 transgender and non-binary people. I am here to support HB 746. I've been providing gender-affirming medical care since 2011, and my practice is based on the standards of care set forth by the World Professional Association for Transgender Health, or WPATH. The WPATH standards set forth the foundational tools for identifying and treating gender dysphoria. The standards are respected by leading physicians both in the United States and internationally, and all major medical organizations agree that this care is medically necessary. The current Maryland policy has a long list of exclusions. One set of exclusions is for facial procedures. Facial features such as jawline and Adam's apple are associated with specific gender. An appearance that does not align with a person's outward gender expression causes internal distress and poses specific safety concerns. By 3 months of age, infants can perceptually distinguish faces based upon differences in gender. A 2020 study found that following facial feminization surgery, all patients had improved quality of life, more feminine gender appearance, and high satisfaction. One of my patients, a bright college student, had difficulty attending her classes due to daily significant facial hair growth that would return each afternoon. She requested electrolysis, but it was an excluded benefit. And this affected her academically and socially as she could not leave her room for more than a few hours at a time. Some of my patients had such terrible discomfort with their speaking voices that they developed selective mutism and would not speak. Following voice therapy, our visits changed from silent to chatty with confidence in finding their authentic voices. WPATH's position is that medical necessity must be determined on an individualized basis with the patient's medical providers. The treatments I discussed today are neither cosmetic nor experimental. They are well-researched, highly regarded, and life-saving. The low-income Maryland transgender community deserves this life-saving care. Thank you for the opportunity to speak here today.
Thank you for the work you do. We appreciate it. Next, we have Emily Scott.
Good afternoon, everyone. Thank you for the opportunity to be here today. I am testifying in favor of this bill. My name is Emily Scott, and I am a Lutheran pastor. I serve 2 congregations that are LGBTQ affirming and that have many folks from the trans community who attend. I'm immersed in the transgender community as someone who ministers to transgender people and as someone who is myself transgender. As a pastor and a Christian, I believe that God created a beautiful diversity of human beings, and some of God's children are transgender. Today is one of the holiest days in the Christian calendar, Ash Wednesday. And on this day, some Christians are marked with the sign of the cross and ashes on their foreheads, as you can see I am, remembering that God created us out of the dust of the earth, and that when we die, we will return to the dust. But death, unfortunately, often comes far too soon for those who are part of the transgender community. The suicide rate among transgender people is astonishingly high. A study from the National Center for Transgender Equity reports 40% of trans people have attempted suicide. Gender-affirming care, however, has been shown to decrease these risks. A study from the Seattle Children's Hospital showed a 73% drop in suicidal thoughts among youth who receive gender-affirming care. I have seen the impacts of dysphoria, which is an extreme anxiety and distress that's caused by one's gender expression not aligning with one's gender identity. I've seen this firsthand in my congregation, and I've also seen it in my personal life. My spouse is also transgender and lost over 10 years of his life to drug addiction. He was someone who was privileged enough to access gender-affirming healthcare. And he is now not only clean, but has earned 2 master's degrees and serves vulnerable people in Baltimore. On this holy day, Christians are called to turn again to the core tenets of our faith. In both the Hebrew Bible and the New Testament, God commands us to care for the poor, the widow, and the orphan. God demands our care for transgender people who qualify for Medicaid because they are among the most vulnerable people in our society. This bill will ease the suffering of God's children who deserve the very best medical care. I care about this bill because I do not want to preside over the funeral services for a single one of my congregants. Transgender people have unique gifts and perspectives and have much to offer our society, but they can only do so when their identity is affirmed, which will allow them not only to survive, but to thrive. Thank you.
Thank you. Thank you for your service and your testimony today. Next, we have Ms. Enriquez.
Thank you, Madam Chair and committee members. My name is Ann Geddes. I'm testifying today as the mother of a transgender child in support of House Bill 746. Our son, Jordan, who was born a girl, developed significant mental health problems as an adolescent, including severe self-injurious behavior and multiple suicide attempts. These problems developed at the same time that he decided for himself that he was not of the gender assigned to him at birth. Because of his significant mental health issues, his father and I mistakenly did not permit him to undertake any gender reassignment measures as an adolescent. Because of his untreated gender dysphoria, Jordan ended up costing the state a tremendous amount of money. At significant cost to the state, he spent 9 months in a residential treatment center, which was paid for by Medicaid. He experienced multiple inpatient hospitalizations, which were paid for by Medicaid. And he lived for 1 year in a residential rehabilitation program, which was paid for by Medicaid. At the age of 19, when Jordan began his gender-affirming treatment, his mental health challenges dramatically improved. He stopped self-injuring, there were no more suicide attempts, and over time, he got sober. He had developed alcoholism. He moved into his own apartment. He finished college. He got off of SSI, then he got off of SSDI, and he is now employed as a software engineer with a well-paying job. Jordan is now a Maryland taxpayer. He is a giver and not a taker, at great savings to the state. Our son's gender reassignment surgery was truly transformative. All transgender individuals should have the opportunity to live a happy and productive life. House Bill 746 would support this end, so please return a favorable report. Thank you.
Thank you for your testimony today. We really appreciate it. Next, we have Kellen Baker.
Good afternoon, Chair Pendergrass and members of the committee. Thank you for the opportunity to testify in support of House Bill 746. My name is Dr. Kellen Baker, and I am the Executive Director of Whitman Walker Institute. Whitman Walker is a federally qualified community health center that serves 20,000 patients annually from the DC and Maryland area. I hold a PhD in health services research from the Johns Hopkins School of Public Health, and my research focuses on the transgender population, particularly the legal and economic aspects of coverage for gender-affirming care. Maryland Medicaid has previously been a nationwide leader in working to ensure that trans people can access the healthcare they need. As the field of trans medicine has advanced, further clarification is now needed regarding the appropriate scope of coverage. In Washington State, for example, legislators updated the Medicaid program in 2021 to clarify coverage for puberty delay medications and a broad and non-exhaustive range of gender-affirming procedures. Like House Bill 746, the legislation also directs the Insurance Commissioner and the Medicaid agency to issue a regular report on access to gender-affirming services across the state. Colorado recently took a similar step through its Essential Health Benefits program. With approval from the federal government, plans must now cover procedures that include, for instance, facial surgeries and electrolysis. An analysis commissioned by the state to assess the cost of this coverage estimated it to be 0.04% of allowed claims. My own recent research indicates that each transgender person in a national insurance claims database incurred less than $1,800 in costs per year for gender-affirming surgeries and other care. Considered on a per member per month basis, the budget impact of that coverage is 6 cents. Maryland's commitment to the health and well-being of its Medicaid population is critical. Gender-affirming care is not expensive when considered from a payer or societal perspective, but it is often beyond the reach of trans people who rely on Medicaid. Communal assistance to individuals in need reflects the core purpose of the Medicaid program, and clarifying that Medicaid supports trans Marylanders in seeking essential healthcare services is both a moral and economic imperative. I strongly urge you to support House Bill 746. Thank you.
Thank you for your service, Doctor. Are there any questions for this panel? I see Delegate Bill Castro.
Thank you so much, Chair.
My
Pinion.
pleasure.
This question is for anyone that can answer it. Oftentimes children are used as a talking point to not support bills like this, but we know that a bill like this is truly important to our trans children. So I'm hoping that someone can talk to the impact that this bill would have on children, but also why it's important to trans children.
I'd like to answer, please. So I'm a pediatrician and I treat children. Study after study shows improvement to mental health, particularly for puberty blockers, which is a class of medication that is completely reversible. It merely delays puberty, so children have time to mature and grow and make sure that they are on the right path and that they don't have to suffer through puberty that's the wrong puberty. It really reduces suffering. It's a very important medication. The current legislation does not address it at all. Maryland policy covers it, and Maryland is providing this care for children on Medicaid currently, but it's not safeguarded. There's nothing in the current legislation that says this will continue to be covered. And so I feel it's very important that we safeguard this life-saving medication.
Thank you so much. And can I please have a follow-up, Madam Chair?
Absolutely.
Thank you. If you could really quickly also talk about how parents play a role in these medical procedures and their involvement in it, that would be really helpful as well.
I'd be very happy to. So medical decisions are made, people can consent for their own medical decisions at age 18, which means any decisions in pediatrics for minors are made as a family. They're made by parents. And parents want to help their children. Parents want to do what's best. Doctors want to do this. We all care about children. We want to help them find the right choice, the healthiest choice. And this is not, these medical options are not available to teenagers to just do what they please without their parents' permission. This is healthcare that is chosen as a family, and parents are asking for these medications.
Dr. Pine, that was very helpful. Thank you for that.
Thank you. Are there any other questions for this panel? I see Delegate Saab.
Thank you, Madam Chairman.
My pleasure.
So I'm looking at the bill itself, and I know I kept hearing the term medically necessary, but as I read on page 3 and everywhere else, I'm just trying to figure out, because some of those terms are actually in, I guess, on the dictionary somewhere, or in the, for instance, some of the insurance companies, what they classify as medically necessary and not medically necessary. But maybe some of the stuff seems to be cosmetically necessary. So for instance, surgery to the face and neck, including facial bone reconstruction or facial bone remodeling. I'm trying to figure out how is that medically necessary, as well as liposuction and face and forehead lift and laser treatment for scars. So how is that medically necessary?
Let me take a stab at that, Madam Chair. I think what's important to note, Delegate Saab, in answering your question, this bill is about dealing with gender dysphoria and someone who has made a part or full transition, not being able to be fully recognized as the gender that they wish to be. And so from that point of view, again, it has to be deemed medically necessary by a doctor, and it has to be prescribed by a licensed healthcare provider. So in that sense, it is medically necessary because of the gender dysphoria, as I believe is defined in the legislation.
So even some of the, like for instance, Care First has few terms, but one of them is clitoroplasty, which is also mentioned in here, that they're classifying it as not medically necessary. So I'm just trying to figure out, so they can potentially deny, if this bill passes, they could potentially deny those people because they're not classified as medically necessary. I mean, I understand your point, but I'm just trying to figure out, because it's very descriptive, specific to a lot of the terms that are, just extremely prescriptive.
The legislation, we provided an amendment that has taken out all of those descriptions. But I think somebody else could better explain the coverage part.
Who will be the best person to answer the delegate's question?
So
Dr. Pine?
Yeah, so I'd like to explain. So things that are considered cosmetic is surgery that's performed to reshape normal structures, things that are there but normal, but someone wants to enhance the way they look to feel or look better. But a medically necessary surgery is performed on something that's abnormal in some way by congenital defects, developmental abnormality, trauma, infection, tumor, or some condition, and gender dysphoria is one of those conditions. So you mentioned something like sort of a facelift or the skin moving back, and people generally think of that as being very vain. Oh, I don't like wrinkles and things like that. But the amount of skin that somebody has between their hairline and their forehead and their skin is very different for women and for men. And so somebody who has a receding hairline and how their hair and skin looks can be very telling to whether somebody has gone through a male puberty or a female puberty. And having their skin and their hairline reshaped can go very far in that person being recognized as female. And a person who's never recognized as female, a transgender woman living as a woman, is never recognized as female, that can be extremely distressing, and it becomes medically necessary to have a procedure to help them become more recognizably female, and because of the distress that it is causing.
Thank you. Thank you, Madam Chairman.
My pleasure. Next, we have Delegate Hill. Oh, I see her hand is down now, but Delegate Bagnall.
Okay.
Oh, Delegate Hill, did you have a question?
Yeah, I did. I just
Go ahead.
want to thank you, Dr. Pine. I think what you're saying, I just want to be clear, what you're saying is that, and I think Delegate Kaiser said they have an amendment to strip out a lot of the specifying language, that you're saying it's a case-by-case decision. And just as Medicaid and Medicare have been covering gender identifying procedures since 2014, that there are, say, they're gender conforming people who might say, you know, I'm upset because I have a receding hairline, and that doesn't make it medically necessary. But when you're carrying a particular diagnosis that's on a DSM code or that carries particular psychological ramifications, there are situations, not everyone, but there may be individuals for whom a particular procedure that in other circumstances would be considered cosmetic would not be. Is that what you're saying? And that
Correct.
you want to
That's
be
what
left
I'm
up to
saying.
medical professionals to?
Right, just the procedure itself, you may not know whether it's cosmetic or medically necessary, but the impact on the person's life and how their particular situation, their particular condition is affecting them may make it medically necessary.
And if I may follow up, Madam Chair, just briefly, but you're not asking for anything more in terms of the decision about medical necessity than any non-transforming person would have. So, right, I mean, so you're asking for equity, but to cover and recognize that some conditions that for certain individuals will be considered cosmetic may actually be medically necessary, and they should be covered as medically necessary.
Yes, people need facial reconstruction for many different reasons, and gender is not the only one.
Okay, thank you.
Thank you. We have next Delegate Bagno, followed by Delegate Krebs. Delegate Bagno.
Thank you, Madam Chair, and thank you to the bill sponsor. If I'm correct, can you just speak to, does this more closely align Medicare, Medicaid with the scope of services that will be available under private insurance? And if anyone can speak to the outcomes when we have this broad array of services in terms of transition in physical and mental health.
Delegate Kaiser, who is the best person to answer that if it's not yourself?
Yeah, I don't think it's myself. I assume Dr. Pine or Sam Williamson.
Thank you. So, Dr. Pine, do you feel comfortable answering, or?
I can start, and if someone else wants to jump in, yes, their private insurances do cover different procedures. There are private insurances that cover facial feminization surgery, vocal surgery, speech lessons. Those things are covered. And as mentioned in the other people who focus more on the financials, when people receive adequate treatment, mental health improves, and then mental health costs will go down. So I don't have an exact financial answer, but the reduction in depression, anxiety, and other mental health costs will improve general health as well.
Thank you, Dr. Pine.
Thank you very much.
We have, my pleasure, Delegate Krebs.
Thank you. And I don't know what the amendments are, but one of my concerns is to, I read the definition here of gender affirming treatment. And it's a little question and a bigger question. So gender affirming treatment, what if you are born a female and you to affirm your gender, you have reasons that you want to affirm your femaleness because you have a problem, you have receding hairline or whatever, facial hair. Would that include those types of people as well, or just people that are changing their gender?
Delegate Kaiser, who's the best person?
I'm thinking Sam or Lee might be the best on this.
I'm happy to answer.
Thank you, Sam.
Absolutely. So this bill specifically ties the gender affirming treatment to current medical standards, such as the World Professional Association for Transgender Health. And those standards are very clear about gender dysphoria and who is able to access it. So no, if it were a cis woman who wanted some of these procedures, they would not qualify under this bill. It's really targeted to transgender and non-binary, two-spirit sort of gender non-conforming people.
And the reason I'm asking the question is because I can think of situations where you could have a person of their birth gender that has situations that are not, that cause them mental health problems just because of something. And it just seems like maybe we're including one group of people and not another group of people, and there could be some, but again, once I see when I see the amendment, which specifics are taken out, but it seems like we're targeting, I understand why for certain things, but then other folks would not be included that might have the same type of a mental health issue because of a problem they have relating to their own gender. I don't know if you understand what I'm saying, but
I think we do understand. And I first say, make sure that everyone sees the amendments. It's mostly stripping out the specific procedure language, and we can get you more specifics on that. But I mean, you bring up a good point, but I don't think that that's a reason to not go through with this for a select small population. And maybe that's something to pursue in the future. But I don't think that's a reason to not support this for a select group of people whose statistics of mental health challenges and of discrimination and abuse within society is so much higher than everyone else that I think adding in other people would not be the right thing at this time.
Delegate Kaiser, if I can also
No,
add.
you can also, you only one person.
Oh, okay.
Actually, I allowed two there, but that's only one. But if you could send it to us offline, that would be great. Okay. Delegate Krebs, anything else? Okay. We have next Delegate Lewis, Robin Lewis.
Thank you, Madam Chair. I was curious to know what Dr. Baker might want us to be aware of.
Thank you.
Very clever. Go ahead, Dr. Baker. Baker.
Thank you.
The rules are the rules. We try.
Sure,
Sometimes we bend it a little because we do have to be flexible, but go ahead.
Indeed. Thank you.
My pleasure.
I just wanted to note that the degree to which gender is important for cisgender people is very thoroughly recognized in a number of state and federal laws, talking about, for example, reconstructive surgery after mastectomy for cisgender women or for people after treatment or prevention of breast cancer is one of the very few federal insurance mandates that exist. So we already recognize there's a very substantial sort of infrastructure, if you will, of laws and policies that make it possible for cisgender people to access the type of procedures that might be needed to address issues related to gendered expression or gendered appearance. And it is only when we are talking about transgender people that we really see these carve-outs where people are then not able to access procedures because of the historical discrimination against transgender people in insurance coverage and medical care.
Thank you, Dr. Becker. Thank you, Delegate Lewis. Any other questions for this panel? I don't see any. Now we're going to go to the favorable with amendment panel. We do have 3 people. First, we have Lee Blinder.
Thank you so much, Chair, Vice Chair, and the committee. My name is Lee Blinder. I use they, them pronouns, and I'm a proud transgender person, as well as the Executive Director of Trans Maryland. Trans Maryland is a multiracial, multigender community power building organization for Maryland's trans community. Trans Maryland runs the state's largest volume name and gender marker change program, offering peer-to-peer guidance and financial assistance to Marylanders who are seeking a name and gender marker change. We also run the state's largest peer-to-peer connection space for trans Marylanders. Through this work, we have talked to thousands of transgender Marylanders about the barriers we face in accessing affirming medical care. The Trans Health Equity Act of 2022 emerged from those conversations, which highlighted to us the clear gap in services for low-income trans Marylanders. Many trans Marylanders experience gender euphoria as a result of accessing gender-affirming care. We also witnessed the many barriers to that care. The others who've testified in support have clarified many of the points that I had, and I don't want to repeat. I will simply say that through the work we do, I will note we are the only service provider in the state working exclusively with transgender clients and serving the whole state, while also being run and led by trans Marylanders. There is no one better positioned to illuminate the need to expand these services. I speak every day to trans Marylanders who cannot afford to access necessary gender-affirming care that would be immediately alleviated by passing this legislation. and putting an end to the current two-tiered care. I also speak to trans Marylanders who can afford this care, and I see firsthand the difference that provides in quality of life and well-being. Modernizing gender transition care through Maryland Medicaid is an easy fix. Passing the Trans Health Equity Act of 2022 is a financially sound decision, a moral and ethical imperative, and brings Maryland in line with the many other states who are leading this coverage of care. For these reasons, we urge a favorable report on HB 746. Thank you.
Thank you so much for your testimony. Next, we have Pam Casemeyer. Susanna, is she still here?
No, they have left.
Okay, how about Margot Quinlan?
Yes, thank you, Chair. Thank you, Vice Chair, members of the committee. My name is Margot Quinlan. I'm here with the Mental Health Association of Maryland, and we're in strong support of House Bill 746. I want to speak today on the unique intersection of mental health and transgender healthcare. Minority stress describes the chronically high levels of stress faced by members of stigmatized minority groups. It may be caused by a number of factors, including interpersonal prejudice and discrimination. Numerous studies show that transgender individuals are at particular risk of psychological distress from elevated exposure to harassment, to discrimination, and to societal oppressions. This minority stress may make trans and non-binary people more vulnerable to the development of behavioral health concerns, such as anxiety, depression, or substance abuse. Alternatively, access to gender-affirming care has been shown to increase mental well-being and has been associated with a significant decrease in mental health treatment over time. It can lead to increased congruence with gender validation and an overall reduction in the minority stress caused by discrimination and harassment. Without adequate medical care, transgender Marylanders are exposed to job and housing discrimination, to harassment, and to interpersonal violence. The state ultimately pays for this rising cost of discrimination through emergency room visits, through hospitalizations, and an over-reliance on our mental health care system. And Maryland is falling behind much of the nation as a result of this. The Mental Health Association strongly supports this bill. We appreciate and support the amendment language provided by Delegate Kaiser and drafted in close partnership with MedChi. We expect this to be a relatively inexpensive change to the state Medicaid plan, yet one that would have tremendous impacts in improving the health and mental well-being of our transgender communities. This care is life-saving, it is medically necessary, and it must be made accessible to all who need it. And for these reasons, we would urge a favorable report on House Bill 746. Thank you.
Thank you for your testimony today. We appreciate it. Are there any questions for this panel or favorable with amendment? Seeing none, thank you so much for being with us. We do have one panel on favorable, Mr. Binns McCulby. Good afternoon, sir. You have 2 minutes.
All right, thank you, committee. I appreciate
My pleasure.
your hearing on this. What we have here is an issue of priorities, and this bill is an extremely sad situation where people have hijacked state agency to work on cosmetic issues, calling it as some type of healthcare. It's not. What I just heard is, in all these cases, is prolific mental illness that runs through these. Complete denial of objective physical reality, utter disregard of this issue is child abuse, and at least one case blasphemic abuse. There were lies about trans children reversibility. The issues that are being changed on children when this is happening to them cannot be redone. And as I look at the list of things, so they're saying that, yes, as you look at page 3 and 4 and 5, of all these type of things, okay, that are talked about, mandibular angle, lateral cathoscopy, lixus intranasal, these are all cosmetic issues. Regardless, committee, of how this is amended, that's the spirit of this bill. This is a, you heard people call this medically necessary. This is pure delusion. The issue that someone needs to have their Adam's apple carved or else, this is akin to like a mobster coming, and saying, it'd be a shame if something happened to your shop if you don't pay us. And this is not kindness. This is not medically necessary. This is mental illness being perpetuated in the political and the lawmaking structure. And this corruption was written not by the delegate, but by a lobby that thinks they're going to run the board on these issues. So your committee, HGO, finance, need to stop sucking up to these lobbies for payola and graft. This is child abuse. I urge you to stop. Thank you.
Thank you for your testimony today. We appreciate it.
Thank
Are there any questions? My pleasure. Any questions for this witness? We have Delegate Kaiser. You're muted.
Madam Vice Chair, if I could,
Yes.
I heard the people who were testifying as being manipulative and all dealing with mental health issues, and it's really hard to let that statement go. And obviously, I find it very heartbreaking. Right now, there's a racing of LGBTQ people in Texas and in other places. But let's be clear, this issue is just about the T's. I learned something last night reading Margaret Quinlan's Twitter feed. Only transgender people can uniquely describe their experiences. But like all marginalized people, I know they need allies. And I suggest that anyone with questions, concerns, discomfort, invite a transgender person to chat and ask about their life experiences. We're not talking about people with mental health issues. We're talking about people who, because of how society perceives them, treats them, it causes the mental health issues. It has a lot to do with how other people treat them. Transgender people are people. They are our friends. They are our family. They are our neighbors. What they are not, and I would just say, shame on you, shame on us, that we are still unfinished in providing civil rights to all, including in the healthcare arena. And so I guess my only question for Mr. McAvoy, given the comments that you made, do you have a medical background?
Do I have a medical background? Yes, I do have some medical background.
What is your profession?
Not going to get into that, Delegate. I get where you're going with this, okay, but what you're trying to do is try and sway this laundry list that you have. You actually had to produce this bill. You actually had to send this down drafting 3 and 4 and 5 pages and call this normal. Did you look at numbers 4, 5, and 6? Can you imagine what you're saying to somebody? You're basically saying to them that you were made not whole, that there's something wrong with you. So when you say that this is something that that the society has done to them, I turn it on you and say, you're saying that they're not whole, that they can't be right unless they get this. I think they're fine as they are.
Sir, you're not answering the question, sir.
I
You
did.
were
I
asked
actually,
the question.
Delegate,
The question was your medical background, given the medical advice you gave us.
I did have a medical background. What I'm
And
telling
that's
you.
it. What is your medical background? Yes or no? Can you tell? If you cannot tell us your medical background, you are not answering the question. Thank you.
Thank you, Madam Vice Chair.
My pleasure. Delegate Johnson.
You muted me.
Thank you, Madam Chairman, and thank you, Delegate. I do have a
You
question.
muted me as I was trying to answer.
Sir, you're done. You did not, you'd say you didn't want to answer. Okay,
I
sir, with all
did
due
answer.
respect to you.
You muted me while I
We're
was
finished.
answering.
We're moving on to the next question that they'll have of you, okay? And I've been very respectful of you in allowing you your time, but she did ask a question and you refused to answer it. So
I did
please be
answer the question.
respectful. Thank you. Delegate Johnson,
Thank you, Madam Chair.
my pleasure.
I was looking at the physical note and I just wondered, I saw that it's for small business, it said meaningful. But when I went over on small business, it just says small business healthcare providers that provide gender affirming treatment may receive additional reimbursements from Medicaid. So I was just wondering where they were getting the meaningful for small businesses in the physical note, if anybody knows.
Delegate
We can find
Kaiser?
out for you, Delegate Johnson.
All right, thank you. Thank you, Madam Chair.
Okay. Any other questions? Thank you so much. And let's always, try to be respectful. We all have different opinions and we must be respectful of that. This concludes the House bill on 746. I want to thank the panelists for coming. We do appreciate your testimony. We value it and we take it into consideration. And thank you for being with us today, okay? We have the last bill of the day, which is House Bill 1080, and that is Delegate Pena-Melnick, Maryland Medical Assistance Program, Children and Pregnant Women. And just for the committee, before we start, I have never done this by Zoom, so I hope everyone is a little flexible. We have someone that requires translation. I have not done that, so we need to be a little flexible with the time, and I'll try to finish early so I can give some of my time. Thank you so much for the courtesy. So good afternoon, Chairman and members of the committee. Thank you for allowing me to present House Bill 1080. This bill requires Medicaid, subject to the limitations of the state budget, to provide medical care and healthcare services to non-citizen pregnant women who will be eligible for Medicaid, but for their immigration status and for their children up to the age of 1. The Maryland Department of Health must apply for a waiver from the Federal Centers for Medicare and Medicaid Services that maximizes the federal funding and the individuals who will be eligible for Medicaid under this bill. So why does this matter, you may ask? Well, nearly 5% of Maryland's population is undocumented. A majority are uninsured. Eligibility restrictions bar them from participating in Medicare, Medicaid, the Children's Health Insurance Program, known as CHIP, and the Affordable Care Act. As a result, hundreds of mothers navigate pregnancy without the care of a doctor, and often see a doctor for the first time when it's time to deliver, when they go to the hospital. This results in high-risk pregnancies that put both mother and baby at risk of serious complications and health risk. Immigration status should not be a barrier to receiving life-saving health care for mothers and children. Lack of access to prenatal care increases the risk of premature birth, low birth weight, and may be a factor in a range of poor health outcomes that we often talk about in this committee. And these women, they experience this. They go into labor early. They have excessive bleeding, breech presentation, fetal distress, and more issues. Maternal mortality rate increases 5 times for women that do not have prenatal care. We have done a lot in Maryland to cover the uninsured. We created the health exchange. We expanded Medicaid to the regular population. We were able with those things to basically reduce the number of uninsured by more than 50%. We went on to create a reinsurance program. We did that, and that helped more than 218,000 people in the individual insurance market. We went on to require a little checkbox when we do our taxes to identify who doesn't have insurance and to be able to connect them to the health benefit exchange and say, do you have insurance? If not, may we connect you to someone that can screen you to see if you qualify for Medicaid or for any subsidies. And oftentimes what the data shows is that a lot of people were able to get covered, and oftentimes for free or very little. What I'm asking for us to do here has been done in 17 other states. States like Virginia, like California, like Michigan, Missouri, Minnesota, Texas, because they understood the importance of covering pregnant women that decided to have their babies. Maryland has the 5th highest population, percentage-wise, of undocumented immigrants, yet we lag behind 17 states. Everything that I said that we have done, we've reduced the number of uninsured, but what's left is 300 and something thousand people that are undocumented, that are not covered. The fiscal note is pretty favorable. While the initial summary states the Medicaid costs increased by an indeterminate but significant amount, the note correctly points out that the majority of that expense will be covered via federal dollars, under the assumption that 30% of the undocumented population will sign up, which is a study that was done by the Maryland Health Benefit Exchange that said that 30% will sign up. the state will see an increase in federal funds by 27.4 million in federal funds to cover this population. While there will be an expected 14.8 million increase in general fund expenditure, this will be offset by a reduced expenditure of $13.4 million, $13.4 million due to higher match rate for labor and delivery. So you see, this bill is essentially cost neutral while providing prenatal and postpartum care for mom and baby. In Maryland, undocumented taxpayers pay over $308 million in state and local taxes every year. They pay into a system like everyone else, but are not eligible for most benefits that their taxes pay to fund. This is really good policy, and I hope that we give it a favorable report. Thank you so much. Next, we have Mr. Larry Polsky. Mr. Polsky, you have 2 minutes. Thank you so much for being with us.
Thank you, Madam Vice Chair, Madam Chair, members of the committee. My name is Larry Polsky. I'm here on behalf of the Maryland Association of County Health Officers in favor of House Bill 1080. HB 1080 helps protect the health and lives of children in the womb and during the earliest and most vulnerable phase of life. Increasing access to basic healthcare services during pregnancy is both a fundamental ethical good and a means to prevent preterm birth and expensive neonatal complications. In addition, extending coverage for women into the postpartum stage allows monitoring and treatment for potentially dangerous conditions to extend beyond pregnancy, including preeclampsia, cardiomyopathy, and postpartum depression. All of these conditions can lead to expensive ER and inpatient hospital care if not properly addressed in the outpatient setting. HB 1080 will be a major benefit not only to the women and their babies who obtain coverage, but also to obstetricians, nurse midwives, and pediatricians who will be able to provide consistent preventive care. For instance, the patient population that will become eligible for insurance coverage under this bill has higher rates of gestational diabetes. Failure to diagnose and treat diabetes during the pregnancy leads to higher cesarean section rates, which are more expensive and have higher complication rates than vaginal deliveries. In addition, babies born to moms with uncontrolled diabetes often have unstable blood sugars, requiring invasive treatment and more frequent admissions to neonatal intensive care units. Preterm birth rates are also higher for women who don't obtain prenatal care. A single preterm birth can cost the healthcare system hundreds of thousands of dollars. Children born prematurely are also more apt to have long-term health and learning problems that can result in significant ongoing costs to Medicaid and local school systems. HB 1080 should decrease preterm births and associated costs. The fiscal note does not take these savings into account. HB 1080 benefits pregnant women, their children, healthcare providers, and the overall healthcare system. For these reasons and more, the Maryland Association of County Health Officers requests a favorable report. Thank you very much.
Thank you, Dr. Polsky, for everything you do. We have next Dr. Michelle LaRue.
Thank you, Madam Chair and members of the committee. My name is Michelle LaRue. I'm the Director of Health and Human Services Department at CASA, and I'm here in support of HB 1080. CASA is the largest immigrant services and advocacy organization in Maryland with membership of over 120,000 Black and Brown immigrants and working families. Over the last several decades, the need of health coverage has been a consistent priority of our immigrant communities in Maryland, and HB 1080 is a critical step in addressing access to care, starting with pregnant people. Annually, our Health and Human Services Department helps thousands of families and pregnant women navigate the health and human system, health and human services system, mostly while limited care options do exist for undocumented pregnant women, it is not enough. Often undocumented and expectant mothers are forced to see a doctor for the first time when they're just giving birth, which gives rise to grave negative health outcomes. While community health clinics and other programs are open to individuals, regardless of their immigration status, they are limited in scope and geography. Emergency Medicaid has long existed specifically to save lives and is available to anyone regardless of immigration status. While it currently covers labor and delivery for uninsured pregnant women, it does not cover prenatal care or is both to the safety of the mother and the baby. Not having access to prenatal care results in 40% increase in neonatal deaths and an increase in maternal mortality, as well as a risk of poor health outcomes. Unfortunately, thousands of mothers across the state or who otherwise meet the income requirements for Medicaid are forced to risk their lives and that of their babies simply because they do not have immigration status and therefore lack proper care. For all of these reasons, CASA urges a favorable report for House Bill 1080. Thank you.
Thank you. Thank you for your testimony. Next, we have Ms. Stephanie Clapper. You have 2 minutes.
Thank you. I'm Stephanie Clapper, Deputy Director at Maryland Citizens Health Initiative and the Maryland Healthcare for All Coalition. Thank you, members of the committee, for this opportunity to testify in favor of this critical legislation, and a special thank you to you, Vice Chair, for being the lead sponsor. Under your committee's leadership, Maryland has one of the best healthcare systems in the nation. Over 400,000 Marylanders have been covered under the Affordable Care Act, and we lead with innovative programs like reinsurance, easy enrollment, and youth subsidies. But there's still more to be done to make sure that all Marylanders have access to healthcare within this system. Though Maryland has cut the rate of uninsured in half, still 6% of Marylanders remain uninsured, with disparities by race and ethnicity. It is critically important that pregnant Marylanders and their babies have access to Medicaid regardless of immigration status. Without it, people have to rely on safety net clinics and hospitals to try to patch together the care that they need. I want to tell you the story of an undocumented woman named Yuri, who in the summer of 2020 was pregnant without health coverage. She did not have access to prenatal care, and it had profound implications for her pregnancy. This means a lot to me because I was pregnant last year. I was expecting twins. One of them didn't make it. I didn't have to wonder whether that would have been prevented if I had access to prenatal care, because I had it. And I have a beautiful son, and he was able to get the care that he needed during my pregnancy and after. Although Maryland is a leader in healthcare in many ways, on this issue, we are trailing behind. Our neighbors in Washington, D.C. and Virginia, plus 16 more states, already provide coverage during pregnancy, regardless of immigration status. It's time for Maryland to join them and give pregnant Marylanders and their babies the best chance for a healthy life. On behalf of the Maryland Healthcare for All Coalition, I urge you to give a favorable report for House Bill 1080.
I'm sorry for your loss, Stephanie. Thank you for sharing. We appreciate it. We have Ms. Iris Rivera, and she has a translator. So I just want you to be a little patient that we may go over the time, and I really appreciate you for the committee members. Ms. Rivera, will you get started? ¿Puede empezar, por favor, señora Rivera?
Ok. Hola a todos, mi nombre es Iris Rivera, soy miembro de casa, residente de Elbridge en Howard County y una inmigrante indocumentada de Honduras. Lo más importante es que soy mamá, tengo 2 niñas, una niña de 6 años y una de 2 meses.
¿Puede parar ahí un momento para que ella pueda traducir? Así lo hacemos despacio. I say, can you stop and so that it can be translated slowly?
Hello,
And the translator.
Hello, everyone. My name is Iris. I am a CASA member. I am a resident of Elbridge in Howard County and an undocumented immigrant from Honduras. But most important, I am a mother. I had 2 beautiful children, my 6 years old and my 2 months old baby.
And for the, un momento, señora, and for the committee, the person translating, her name is Viviano Lozano. Señora Iris, puede seguir. Miss Iris, you can continue.
Estoy aquí porque creo que todas las madres embarazadas deberían tener salud médica.
I am here because I believe that all pregnant mothers should have health care.
Desde que vine a este país nunca he sido elegible para los programas de salud de estado y tuve que pasar por mi último embarazo sin atención médica.
Since I moved here, I have never been eligible for state health insurance, and I had to go through my last pregnancy without health care. During
Durante mi último embarazo traté de recibir ayuda de las clínicas comunitarias que están disponibles para personas como yo, pero fue muy difícil porque algunas clínicas no ofrecen servicios médicos para personas embarazadas.
During my last pregnancy, I tried to the best to rely on the community clinics that provide care to people like me, but it was very hard. Some clinics don't offer service for mothers.
Es horrible que por no tener documentos no nos atiendan a nosotras las mujeres que estamos embarazadas y es inhumano que nuestros hijos que no son nacidos aquí tampoco tengan ese derecho.
It is horrible. It is horrible that people coming like me don't have no attentions to getting health care for the females, for the women who are in pregnancy, and it's inhumane. They are children, they don't born here, don't have the right to have health insurance neither.
Tampoco tengan ese derecho a obtener un seguro médico o poder ser vistas por un doctor regularmente como mi hija Suani de 6 años que cuando llegamos aquí tenía 2 años.
It is inhumane that our children to come here, they don't have any health insurance and they cannot be seen like my daughter, Suani, she's years old and she don't have no health insurance. And not even when we arrived, she was only 2 years old.
Señora, tiene que empezar ya a terminar porque el tiempo se acabó. You have to wrap up a little because it ended the time, okay? Puede terminar, dígame una oración, la última.
Lo que yo pido a todos ustedes que por favor podamos tener un apoyo a mujeres como yo que están embarazadas o estuvimos y a niños pequeños que no nacieron aquí.
Today, as is considered for this important bill, and ask that you please think of me, think of my children, think of my baby, think of thousands of mothers and families like me.
A obtener un seguro médico, ya que poder ser visto por un doctor es un derecho mínimo como ser humano que somos. Por favor, apoyen la ley de equidad para bebés saludables HB 1080. Muchas gracias por su atención.
My immigration status doesn't mean that I don't deserve right to a doctor. We support the Healthy Babies Equality Act, HB 1080, and thank you very much for your attention.
Okay, thank you for being with us. Gracias por estar con nosotros. And to the committee, thank you for your patience. We have next Pam Casemeyer.
Hello, members of the committee, Pam Casemeyer. I'm here on behalf of MedChi, but also the Mid-Atlantic Association of Community Health Centers, the Academy of Pediatrics, and the American College of Obstetricians and Gynecologists. And just to save you some time, because I know it's gotten late and you've heard a lot of information already, a few key points to point out. One, as you've heard already, these women already are entitled to emergency Medicare for delivery and labor and delivery. As you can well imagine, if you can give them prenatal care, those outcomes are going to be better, which not only is good for the health of the mom and her family, but it saves the healthcare system money. It saves all kinds of longer-term health issues and costs. So one is this actually puts the preventative care around what they already get covered to make for better outcomes. Secondly, the same is true of the baby and 1 year postpartum. Last year, you extended for regular Medicaid care to 1 year postpartum because there was such good evidence that the health outcomes for the mom and the babies are much better for that period of time, much of which when they can identify initial issues that could cause long-term health implications for the individuals, but quite frankly, for our healthcare system. So we're really here because it's cost effective, but also really wraps around the services that'll help what they already have coverage for now be more successful and their health outcomes better. So we strongly urge a favorable report on this legislation, both for the moms and babies that will be served, but also for our healthcare system as a whole.
Thank you so much, Ms. Case-Meyer. We appreciate your testimony. We now will open it to question. We do have another panel, an unfavorable panel. This is the favorable panel. Are there any questions? We have Delegate Robin Lewis.
Thank you, Madam Chair. I love working on a multicultural, multilingual committee, someone who speaks different languages. My question might be best answered by yourself, Madam Chair. Senora Isabel mentioned that she has a child, school-age child, who's not eligible for health coverage, but I thought that in Maryland, all children are eligible for CHIP. And if that's the case, can her child be seen?
Casa is with her. ¿Está ahí la señora todavía?
No, ya se fue.
Ya se fue, she left. Yeah, but she should be able to be seen, and I'll follow up with Casa.
Thank you so much. Please.
My pleasure. Delegate Bagno.
Thank you, Madam Chair, and thank you for this bill. In terms of the work that we've been doing on addressing maternal and fetal mortality in Maryland, how important is this bill in conjunction to that work?
It's really important because basically maternal mortality rates increase when you don't have prenatal care. And some of these women do not get to see a doctor until they are in the emergency room ready to have birth. So if there were any issues with that baby, they wouldn't know at all because a doctor has not touched them, has not seen them.
And just a quick follow-up, if I may.
Sure.
But the maternal and fetal mortality rates are reflected regardless of immigration status. Is that correct?
That is correct. That is correct.
Thank you, Madam Chair.
My pleasure. Any other questions? Seeing none, thank you very much. We are now going to an unfavorable panel, and that is Mr. Vince McCobie.
Thank you so much.
Good
committee.
afternoon, sir.
Thank you. I appreciate it. Hope you can hear me all right.
Yes, we can hear you.
As I look at the bill, this says subject to the limitations of the state budget, and that always gets into a tricky situation because who's deciding that? What you're requesting here is comprehensive medical care and services for non-citizen pregnant women. As said, and I know this for a fact, that we offer emergency service, pregnancy services. And though, yes, we would want more for children who don't know what country and don't care what country they're being brought into. Okay, but we also have to put this in perspective of the grand scheme of things. What other country would we go to and have that type of care, even limited as it is? Probably a handful in the entire globe. We're a marvelous country. Maryland is more than generous. And I say this in the backdrop of 10% inflation, people who are hurting financially and have been due to COVID, and that we already provide this care. And we know that we have clinics. We know this for a fact in those high traffic areas where we have a lot of illegal aliens. And then we're trying to ensconce this in our code. The problem with that is that what we're doing is we're saying that we're going to, even though we're already helping, we're covering it, that we're basically saying what parts of the federal law that we're going to disregard. And that's where the rub comes in, because once you do this, then you're encouraging illegals to come to our state. We have 2 million undocumented people that came just since Biden took office. We don't know anything about them. And when we factor all that in, you can say that we're going to have a net zero. That's sort of like him saying that we're going to spend $3 trillion, but it's going to cost us zero. I think that there's a lot of financial fallacies in that. We should take care of our children. I don't care where they come from. Okay, we need to look after them.
Thank you, sir. Your
Ensconcing it,
time has
though, is the
expired.
wrong way to go. Thank you, committee.
Thank
Have a
you.
good night.
You too. Thank you. Hold on a second. There may be questions for you. 1 minute. Are there any questions for this witness? Okay, seeing none, thank you, sir, for being with us. The committee does appreciate your testimony. And for the committee, this actually concludes the bill hearing on House Bill 1080, and it actually concludes the work of the day. Thank you for your patience, and I hope